we get started. So I am turning on the recording. This meeting is being recorded. It'll be posted to the OHA's website probably in the next week or so. Um, yeah, and apologies. With that, we're going to start with roll calls and introductions. But one more reminder for those in the audience that have joined us. We ask that you rename yourself to add your affiliation if it's a pharmaceutical company or if it's a CCO. It lets us accurately capture that for the minutes. So we would appreciate that. I have a few more staff members I'm making co-hosts as well. Again, the meeting is being recorded. And with that, we're going to start off with roll call and introductions. We'll start with let's see, make sure I expected, nope, no Tim. Tim won't be joining us today. Karen, as I said, is planning to join us. She's running a little bit late. So Robin, we're going to turn it over to you.
I'm Robin Moody, Executive Director of All Smiles Community Oral Health, joining by phone, but we'll switch shortly to my computer. Thank you.
Thanks, Robin. Bill is unable to join us at this meeting. So Doug, we'll turn it over to you.
I'm Doug Carr, Chief Medical Officer at Umpqua Health.
Thank you, Doug. And Russ?
Hey, I'm Russ Huffman. I'm a psychiatric nurse practitioner at Salem Health.
Thank you, Russ. Dr. Onishi Eriko was not able to join us as well. So Eddie, we'll turn it over to you.
Eddie Saito, Associate Professor at the School of Pharmacy at Pacific University and Clinical Pharmacist with Virginia Garcia.
Thank you and welcome. Pat?
Hi, everybody. Pat DiMartino. I'm faculty at OHSU in the Division of Pediatric Hemonc.
Welcome, Pat. Thank you. Kat, back to you if you've got control of your microphone.
I do. This is Kat Livingston. I'm the Medical Director of Health Share of Oregon, and I'm also a practicing family physician at OHSU.
Welcome, Kat. And Stacy. Stacy's the chair of the P&T Committee. Let you close it out for the committee members.
Perfect. Hi, everybody. My name is Stacy Ramirez. I am faculty at OSU College of Pharmacy and a clinical pharmacist and the director of pharmacy for the community health centers of Benton and Lynn counties.
Great. Welcome, Stacy. And we'll turn it over to staff.
Jennifer Bowen, Executive Support Specialist with the Oregon Health Authority.
Welcome, Jennifer. I'm turning my camera on for just a moment, but then I'll turn it back off. Roger Citron, Director of the Drug Use Research and Management Program, and we help provide clinical support to the OHA and have a team with us. So thank you.
Thank you, everybody, for joining. This is Trevor Douglas. I am the Pharmacy Director for the Oregon Health Authority.
Hello, I'm Dave Engen, a clinical pharmacist with OSU's Derm Group.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators for the Derm Group.
And I'm Andrew Gibler. I'm the clinical pharmacy manager with OHA and also have a faculty appointment with the Derm Group.
My name is Kyle Hamilton. I'm the pharmacy drug coordinator with the fee-for-service pharmacy side here at Oregon Health Authority.
I don't think Megan's
And I don't think Megan's.
Okay.
No, she's not. So to you, Deanna, thank you.
All right, I'm Deanna Moretz. I'm one of the pharmacists with the Drug Use Research Management Group at the Oregon State University College of Pharmacy.
I'm Amanda Parrish, the coordinator for the Mental Health Clinical Advisory.
I'm Kathy Centena, and I'm a clinical pharmacist with the OSU Derm Group.
My name is Sarah Servid. I am the P&T clinical coordinator with Sarah Fletcher with the Derm Group.
I'm Lance Starkweather. I'm the pharmacy manager with Gainwell Technologies.
And I'm Dee Weston, Deborah Weston, I go by Dee. I'm the pharmacy program policy advisor with OHA.
Hello, my name is Brandon Wells. I'm the pharmacy program analyst for the fee-for-service program at OHA.
And Ted Williams, a known entity to many, is not able to join us today. But I'm going to back up for 1 second. Karen, you were able to join us. I made you a co-host. Are you able to unmute your line and introduce?
Yes, thank you, Roger. This is Karen Michelson. I'm the pharmacy director for the Coquille Indian Tribe in Coos Bay, Oregon.
Excellent. Thanks for joining.
Of
So
course.
now we have a conflict of interest declaration. Just wanted to notify everybody that conflict of interest is very important to be disclosed to the Oregon Health Authority. All staff for the OHA and all of the staff for the Durham Group and contractors with Gainwell, I'll have a conflict of interest declaration form they can complete and submit to the OHA. Additionally, anybody wishing to provide public comment, either on our draft docs or in person today, are asked to fill a short conflict of interest declaration form out so the committee is aware of any potential conflicts. So at this time, we ask if there's any additional conflicts that the committee has not previously disclosed to the OHA that they need to bring to the attention of the Oregon Health Authority, or if there are any topics for which you need to recuse yourself today. All right, I didn't expect any, but still wanted to have that opportunity. So with that, we have the approval of the agenda and minutes. For those in the audience, if you're following along on our website, we have the posted packet and materials. If you are following along, we'll post slides up, but we're on page 4 in the packet. We have the approval of the agenda from the August meeting. It's been sent to the committee in advance. They had an opportunity to review. So we'll turn it over to the committee. Are there any edits that are needed? Or if not, we would entertain a motion to approve.
Motion to approve.
Second.
Thank you. Thanks, Betty.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Thank you.
Thank you. Now we have the department update. And Andrew, I don't know if you're doing all of it or if Trevor or Dee are going to be provide any, but I'll turn it over to Andrew.
Well, thank you, Roger. I'm sure they can provide anything on this, but thank you again for volunteering your time to be here today with us. We really appreciate it. Just a few updates. We want to remind our industry representatives that we have limited time and bandwidth. So going into 2024, we've created some dedicated limited blocks of time to meet with industry each quarter. And this may mean that we are not able to meet with you in a time frame that you might prefer, but we really appreciate your understanding on this. And we appreciate the comments you also provide during these meetings to the P&T committee members. But if industry representatives would like to meet with any of the members of the OHA pharmacy team or Roger, please contact Kyle Hamilton directly for scheduling. And Kyle will be able to ensure that all the relevant OHA pharmacy members are included on the invitation and are made aware of the meeting and the reasons for the meeting. And there is I believe, a policy paper that was posted to our website recently, so you can take a look at that. Also wanted to let the P&T committee members and others, of course, know, and you've heard of this, but OPAL, which is the progestin-only oral contraceptive called Norgestrel, the first OTC oral contraceptive to be approved in the U.S. That'll be made available next year. And then there's also a couple of OTC intranasal naloxone products, which is the rapid-acting opioid reversal agent, that have also been approved. And so OHA is working with on creating policies that would allow OHP members to run these products through the plan for coverage. And also, just of note, of interest, also pertaining to naloxone, House Bill 2395 was passed and signed by the governor. It goes into effect in January. And that creates a standing order which is a statewide prescription for quick-acting reversal agents, opioid reversal agents like naloxone. So pharmacists in Oregon have long been able to prescribe naloxone, but not all of them are enrolled as a provider with the Oregon Health Plan. And this law allows a public health officer with public health to create a statewide prescription for anyone in the state to obtain naloxone at a pharmacy in Oregon. And then I think we have some P&T committee member openings opening up. Maybe Roger, you can speak to that. And if Trevor and Dee want to add anything else, we can go to them.
I appreciate that, Andrew. First of all, we do have 4 committee members whose terms expire at the end of the year. Bill Orger has been with us since the inception. In fact, he predated the P&T Committee and was on the HRC's Pharmaceutical Subcommittee, but he's hanging it up at the end of the year. So we're going to be looking for a physician, either MD or DO, licensed and actively practicing in the state. We also have a committee member. Or a public member, Robin Moody. Appreciate all the time that you've invested in this. That has indicated that she's not going to wish to be considered for reappointment. And we have 2 pharmacists whose terms will be ending, and they are encouraged to reapply if they're interested in being considered for reappointment. So, as Andrew said, there will be openings that will be considered for appointments. They're 3-year terms. The information is available on the OHA's website, and I'm always available through an email to answer any questions. So with that, Kat, I see you have your hand up. I want to see if you had questions for Andrew on some of the information he shared.
I did. I was going to save this discussion for the opioid reversal agents class update about OTC naloxone, but I just really appreciated the update about both the new OTC products, both the birth control pill as well as naloxone, and the discussion about making sure that these are covered for OHP members. It seems like the other element of that is really the workflows that are happening in the pharmacy to really, encourage if people are interested in making sure that they're using OHP to cover these rather than paying out of pocket. So I think one of my concerns is that people will end up paying out of pocket because they don't realize that these are covered fully with no co-insurance and copays. And so I'm curious if there is a plan to develop sort of best practice workflows, or, what is the opportunities to engage our pharmacies and making sure that they're, offering this as a covered benefit as people are trying to get OTC medications.
That's also very important for me. I think communication is going to be key to the success of this. And I've reached out to the Board of Pharmacy to help them understand the nuances of the law and communicating that out to pharmacy licensees and pharmacies. And I think it's important for payers also to do the same. And so we hope to coordinate that communication plan before it goes into effect in early 2024, but you're absolutely right.
Yeah, I even wonder.
Always been detailed yet, though, how that looks.
Yeah, that makes me wonder, is there like continuing pharmacy education? Is there an opportunity for sort of a OHA or pharmacy board sponsored education that really is, that fulfills education requirements and also helps support and make sure that our members have no barrier access to these medications?
I can make that recommendation to the board. Yeah, sounds good.
Thanks for that, Kat. Any other questions? Thank you, Andrew. Again, if you have any thoughts or concerns or questions, you can always email us or Trevor or Andrew, and we will respond with best we can or engage the right people. We're now moving on to the consent agenda. It's standing on our meetings. It allows us to go through information where typically there's no new clinical information that needs to warrant any changes, and we're just looking at certain classes to review an executive session. In addition, this time of year, we have posted our CMS annual report and P&T annual report. Those have been out there for review, but we'll turn it over to the committee to see if there are any of these topics that you wish to pull off of the consent agenda to discuss. And if not, I did have one member that signed up to provide public comment, specifically in the substance use disorder literature scan. I am looking in the members in the audience, and I don't see John Landis from Brayburn. Appreciate the eyes from my team or anybody else if you see John Landis from Brayburn. So I don't see that. So we are not going to hear his public comment. So with that, we would entertain a motion to approve the consent agenda.
So moved.
Thanks, Robin.
Second.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Hey, Roger, I just have a point of clarification question.
Yes.
So If we had entertained public comment, does that mean that we have to remove the topic from the consent agenda?
It does not.
Okay.
So the public always has the option to comment. They would provide that comment. I would give them their up to 3 minutes, and then ask the committee if they had any questions. If not, we would move on to asking for the consent agenda to be approved as we just did.
Perfect. All right. Thank you for clarifying.
Yeah, thanks for asking. So with that, if you're following on the packet, we'll turn it to page 86 on the packet of materials and turn it over to Kathy Centena.
Great, thanks, Roger. Yeah, so today I'll just be going over a brief RSV-PA update. The purpose for this is to summarize the new therapies for RSV, Beyfortus and Abrysvo, that were recently approved by the FDA, as well as highlight some of the current practice recommendations for RSV prevention, and then how these all affect our PA criteria for palivizumab. The current policy is that palivizumab is available with a PA for those infants and children who meet the PA criteria guided by the American Pediatric Association and are consistent with the current advisory committee on immunization practices, or the ACIP recommendations. Now, these two new agents aren't under the purview of the P&T committee, so the focus will really be on these preventative treatments and how they impact our PA criteria for palivizumab. So just a little bit of background on these new therapies. Nirsevimab, brand name Beyfortus, was approved in July of 2023, and it's an RSV F protein-directed fusion inhibitor, which is similar to palivizumab, that was approved for the prevention of RSV in all neonates and infants born during or entering their first RSV season, or in children up to 24 months of age who remain vulnerable to severe RSV disease through their second RSV season. Now, palivizumab should not be given to infants who have already received nirsevimab in the same season, because we just don't have evidence, and the manufacturer actually recommends against this. Additionally, the manufacturer states that there's no data on substituting Beyfortus if prophylactic treatment has already been initiated with palivizumab. It is noted that nirsevimab, or I'll just say Beyfortus, that's a little easier, may be given in the second RSV season to those infants who are up to 24 months of age who did receive palivizumab in that first RSV season. Again, there's no evidence to support the use of Beyfortus in a baby born to an individual immunized against RSV during their pregnancy. So this would be women who received Abrysvo that we'll talk about next. So Abrysvo was recently approved for the prevention of RSV in those individuals 60 years and older. And then in August of 2023, it received the additional indication for active immunization of pregnant individuals at 32 through 36 weeks gestational age for the prevention of lower respiratory tract disease and severe LRTD caused by RSV in infants from birth up until 6 months of age. And again, now we don't have any evidence to support the use of palivizumab in infants that were born to individuals that did receive this vaccine. A couple guideline recommendations that have been updated. The first is actually from November of 22, and it's just from the American Academy of Pediatrics that speak to the fact that more than 5 consecutive doses might be needed of palivizumab for certain infants and children that are in areas in which RSV activity persists at high levels within a given region, with interseasonal variability that we saw during the 2021 to 2022 RSV season due to the precautions taken during COVID. Now, the next update was done in August of 2023, and this relates to the approval of Beyfortus, which recommends that a single dose of Beyfortus be used in all neonates and infants born during or entering their first RSV season, or in children up to 24 months of age who remain vulnerable to severe RSV disease throughout their second RSV season. And they also go on to recommend that palivizumab should also be used in those neonates, infants, or children who are not able to access Beyfortus. Now, the CDC came along with similar recommendations in that they recommend Beyfortus for all infants under 8 months and those older than 8 months with risk factors for severe respiratory illness due to RSV. And so the recommendations for changes to the PA criteria actually only apply to number 3. You can see the standard wording there in number 1 about the diagnosis being treated. And then excluding those infants in number 2 that have received prophylaxis and then had a breakthrough RSV infection in number 2. And then number 3 is a change that I'm recommending. It said that is the request consistent with the current advisory committee on immunization practices recommendations for combination prophylactic agents outlined below. And so so currently you can see there for 2023 that concomitant therapy is not recommended. So as long as it is consistent with what's being recommended, again, because we don't have a lot of evidence at this point, then they go ahead and proceed to number 4, which is our criteria that we've had for a long time based on the 2014 guidelines from the APA that were reaffirmed in 2019. So we can go through that whole criteria, but there's no changes, and there's been no changes related to those groups since, like I said, 2014. So that's all for the PA criteria, unless anybody has specific questions and they would like to go through it in more detail. But the current recommendation then is to update the clinical prior authorization criteria for palivizumab to align with the advisory or the ACIP recommendations for combination use of prophylactic therapy, and then prevention with more than one agent. Each RSV season is currently not recommended. And at this time, I'll take any questions.
Great, Kathy. Yeah, questions for Kathy. We do have public comment. Dr. Tara Gonzalez is with Sobi, manufacturer of Synagis. I've made you a co-host for this public comment. Are you able to unmute your line?
Are you able to hear me?
You bet we can hear you, Dr. Gonzalez.
Yeah. Okay, well,
with that, we'll give you up to 3 minutes to address the committee, so the floor is yours.
Fantastic. Good afternoon. My name is Tara Gonzalez. I'm the Senior Medical Director for Sobi North America for the Synagis franchise. Thank you for the opportunity to present information on Synagis, also known as palivizumab. Synagis is a humanized monoclonal antibody produced by recombinant DNA technology that exhibits both neutralizing and fusion inhibitory activity against RSV. Synagis was approved by the FDA in 1998 and is an FDA-approved product available for the prevention of serious lower respiratory tract disease caused by RSV in children at high risk for RSV disease. Safety and efficacy of Synagis were established in children with bronchopulmonary dysplasia that required medical treatment within the previous 6 months or 24 months of age or younger at the beginning of the RSV season. Infants with a history of premature birth, those who are less than or equal to 35 weeks gestational age, who are 6 months of age or younger at the beginning of the RSV season, and children with hemodynamically significant congenital heart disease who are 24 months of age or younger at the beginning of the RSV season. As you may be aware, the American Academy of Pediatrics Committee on Infectious Diseases published an updated guidance on palivizumab prophylaxis in high-risk infants and young children in July of 2014. The guidance asserted that preterm infants without chronic lung disease born at 29 or 35 weeks gestational age would not have a substantial clinical benefit from RSV prophylaxis and thus remove recommendations for palivizumab prophylaxis for this gestational age group. In June 26 of 2023, the American Academy of Pediatrics Committee on Infectious Diseases published their latest technical report on palivizumab prophylaxis in infants and young children at increased risk of hospitalization for respiratory syncytial virus infection. This updated technical report reasserts their statement that palivizumab be recommended for preterm infants who are less than 29 weeks gestational age and who are less than 12 months of age at the start of the RSV season. Preterm infants who developed chronic lung disease of prematurity defined as gestational age of less than 32 weeks gestational age, and the requirement of greater than 21% oxygen for at least the first 28 days after birth, and those who continue to require medical support during the 6-month period before the start of the second RSV season, as well as children with hemodynamically significant congenital heart disease during their first RSV season. The August 1st, 2023 edition of the AAP News highlighted a letter written by the current AAP president, Sandy Chun, MD, urging health officials to develop a comprehensive strategy as new RSV prevention modalities roll out, including continued support of palivizumab use for the prevention of RSV disease in high-risk infants for the upcoming season. So based on today's testimony, Sobi requests that Synagis continue to be administered to infants at greatest risk for severe RSV disease and preserve physician choice. Thank you for your time, and I am happy to answer any questions you may have.
Thank you, Dr. Gonzalez. Any questions from the committee for Dr. Gonzalez?
I'm just curious, is it hard for the like during the PA process in like adjudicating approval criteria number 3 to figure out if mom did get vaccine? Or is that just something that we look for in provider notes?
So is that a question for me or a question for your committee?
Oh, no, sorry, that was for maybe the P&T committee or the OHA staff.
So we hope that we can see something in the record. We'll also ask the question, but this is also kind of new and in addition to the criteria, Pat. So it's something that we're going to be exploring as we entertain requests for Synagis. Generally, this is prophylaxis, but it depends on the date of the birth of the child and probably the timing before we could see that in the system. It's a good question.
Yeah, it seems like a unique challenge to have this be a vaccine in somebody else's record, but just curious.
Can I offer a little bit of I don't know, a little bit of clarity? So the maternal vaccine is only going to be offered between 32 and 36 weeks gestational age. So for the preterm infants that we're talking about, and those who were born at less than 29 weeks gestational age, those mothers would not have qualified to get that vaccination.
And for people vaccinated in Oregon, we do have a vaccine registry. So if providers are able to access the Oregon alert system, they should be able to find vaccination history if the person has been vaccinated in Oregon, I would hope.
Does that kind of answer your question, Pat?
Yeah.
Excellent. But you're right, challenge, and we'll just try to see how we connect the dots that the provider, we hope that they look for that immunization record and are good stewards before they would submit a request for an infant to get coverage for the Synagis. Any other questions?
I'll motion to approve then, if that's not premature.
It is not.
Second, this is Karen.
Thank you, Karen.
All those in favor?
Aye.
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 Anyone opposed? And abstain? All right, thank you.
Great. Turning to page 96 in the packet of materials, we're going to little deep topic here with gene therapies. We had posted, Oregon is a member of DERP, Drug Effectiveness Review Project. They have authored some reports that we, when able, bring forward to the committee. We translate those into the summaries that are in the packet. But we'll turn it over to Sarah Fletcher, and again, page 96 in the packet.
Thanks, Roger. Like you said, I'm going to go over 2 DERP summaries related to 2 different gene therapies and then a new drug evaluation on a 3rd gene therapy. And my plan is to do each one individually and vote on it individually. And we'll do public comment associated with each as we get to it, just to try to not confuse them because of some similarities. So for the first one, this is a gene therapy for beta thalassemia. If you go to the next slide, it was to review evidence based off of the DERP summary report. And this medication is called Zynteglo, or betibeglogene autotemcel. Next slide. For some background, beta thalassemia is an inherited blood disorder that affects the production of healthy blood cells. There's a lot more complications to the complexity of that, but that's on a basic level. It's most prevalent in people who have ancestry in Asia and the Mediterranean basin, and there are multiple genotypes, and these genotypes can have different severities. Patients with the most severe disease are transfusion dependent, and they can also get iron overload from transfusions. There are some therapies that can be given to these patients, including splenectomy, stem cell transplants, which can be curative, but are most effective in younger patients with sibling matched donors, as well as luspatercept. Next slide. So Zynteglo was approved in August of 22, and it's approved as a stem cell-based transplant therapy using a lentivirus vector, and it's approved in adult and pediatrics with beta thalassemia who are transfusion dependent. Also, just to note, this medication got conditional marketing in the EU and UK for patients who were suitable for stem cell transplant but didn't have a donor and who were not the beta-0 genotype. And the medication company did remove this drug from marketing, or request that it be removed from marketing in 2021 and 2022 in the EU. So it's not marketed there. They didn't seek full approval. So for the next slide, the approval of this was based off of a couple different small studies. One is the North Star study, which is a pooled phase 1 to 2 trial. It's open label, single arm, non-randomized. And the North Star 2, which is also the same study design. The comparator was before and after with the same patients, and both had about 20 participants. Most of the participants were in their teenage years, and most were Asian, which makes sense with the clinical history for this disease. About 41% were that beta-not genotype in the original North Star study. They were all transfusion dependent, and HIV and hepatitis B, C were excluded. And then I want to note that HIV medications have to be stopped to even prep for the apheresis to be able to create this drug. The duration of follow-up was about 26 months, and the primary outcome for the first North Star studies was just engraftment, but transfusion independence was a secondary outcome. And you can see overall about 68% of patients did get transfusion independence. That was lower in the beta-not genotype, which tends to be a little bit more of a severe form of the disease. In North Star 2, the transfusion independence was 91%, but that genotype was excluded. If you go to the next slide, some of the limitations for this trial are pretty clear. It's got a high risk of bias. It was very small, single arm, open label. The second study did exclude the more at-risk genotype. And while it did include in the inclusion criteria enrollment up to 50 years, only the oldest patient was 35 years old. And we know from normal stem cell transplants, it's usually more effective when patients are older. And we don't know what the durability of response. And so limited duration, we've only got a few years data at this point. For the next slide, as far as safety, there were no deaths. There were serious adverse events, which is expected given that you have to do myeloablation to get this particular therapy. There were grade 3 or higher febrile neutropenia and mucositis in 51% and 63% of patients. The hospitalization to discharge duration was about 44 days for this process. And some of the warnings and precautions in the package insert include the risk for insertional oncogenesis and that the patient should be monitored lifelong for malignancies using blood testing, blood levels every year, as well as monitoring them for things like hypersensitivity reactions during the infusion. If we go to the next slide, we're going to cross over to the packet onto page 108. I'm going to go through the PA criteria. This one's fairly simplistic. It's asking for the indication, as long as the patient hasn't had gene therapy for something else, confirmed beta thalassemia, and we're asking to document the genotype just for confirmation of the beta thalassemia, but also if the indication does end up changing with that different subtype and it's studying around the beta-not. So if you scroll down further, we have transfusion independence or transfusion dependence defined as it was in the studies as far as weight-based for patients of any age or the number of transfusions per year for patients over 12 years old. I've got the patient range between 5 and 35, which matches the study population. And as I mentioned, with normal stem cell transplants, the older a patient is, the less likely it is to be successful. And if someone is under 5 years old, there is a weight limit, and that's to be able to create get the amount for apheresis to be able to create the drug. It's not an arbitrary limit. And that was in the protocol of one of the trials. Cirrhosis and advanced liver disease matches some of the safety warnings that we have. And then active and chronic infections such as HIV, Hep B, and Hep C, which this is a myeloablative process. And so it does put patients at risk for infection. And I've already mentioned that HIV medications have to be stopped to be able to create this drug. And then we just have a few general questions as far as safety because of the myeloablative process and the ongoing follow-up that a patient would need, and then pregnancy questions that are pretty standard. So are there any questions from the committee for this particular medication? And I don't think we have public comment for this one, if I'm correct.
That's correct.
The recommendations are to recommend Zynteglo as non-preferred and to apply the PA criteria as listed.
I might propose that on approval criteria number 7, we omit the upper age limit of 35. I don't think that that should be like an absolute contraindication to a myeloablative regimen. And I know it was the study inclusion criteria, but I think practically, given the label, 35 plus, I think is reasonable.
Okay. One of the study inclusions did go up to 50. They just didn't enroll anyone that old.
Yeah, it would be pretty
Get off
surprising if we got
entirely?
utilization in 40 or 50-year-olds, but I think it's possible there could be a small number of folks interested.
Okay.
Any other committee members want to comment on that recommendation or comfortable with it? Sounds like they're comfortable. Thank you, Pat. Any other questions or comments on the proposed criteria? Excellent. So again, the recommendation is to approve to make Zynteglo non-preferred and to apply the proposed PA criteria as amended.
Motion to approve.
Second.
All those in favor?
Aye.
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 Anyone opposed? And abstain? Thank you.
Okay. Next product is going over the DERP summary for a gene therapy for hemophilia B. If you go to the next slide, this one is on, I'll attempt to pronounce it, intranacogene dasaparvovec or Hemgenix for hemophilia B. Next slide. For background hemophilia B, it's a recessive X-linked disorder that results in a factor IX deficiency, and it primarily affects males assigned at birth. Some of the complications from this are things like hemophilic arthropathy, pain, and disability, where you can get bleeding into joints over time that cause inflammation and joint destruction, and it can be really difficult over the years when bleeding can't be controlled. The treatments for most patients are factor IX replacement, and that can be given on demand or prophylactically. In general, the disease can be rated as severe if the normal fixed level is less than 1%, moderate 1 to 5%, and then mild at 5 to 40%. Those with a level of greater than 5% are less likely to get spontaneous bleeds, and anyone who has a level of less than 2% is likely to be treated with prophylaxis rather than just on-demand therapy. Go to the next slide. This medication was approved in November of 2022, and it's an adeno-associated virus vector-based gene therapy. So it's a single infusion. There's no myeloablation associated with it. The approval is for adults with hemophilia B who have one of three things. One is a factor IX, they're currently taking factor IX prophylaxis therapy, or a history of current or historical life-threatening hemorrhage, or repeated serious spontaneous bleeding episodes. And I'm going to detail those a little bit more when we go into the trial. So if you go to the next page, the approval for this was based off the HOPE-B study, and it was a phase 3 open label, single arm, non-randomized study. It used intra-subject comparison from the baseline period of 6 months before the therapy to 7 to 18 months after the gene therapy was established. So 0 to 6 months was where they were not getting efficacy data right after the infusion. There were 54 participants. The mean age was 41, and they were 71% white, and the hemophilia severity was severe of 81%, so that was less than 1% fixed level, or moderately severe, which was 1 to 2%. The inclusion were men with anticoagulant activity of 2% or less with continuous prophylaxis for at least 2 months, and the patients were excluded if they had a factor IX inhibitor, uncontrolled HIV, or liver fibrosis. The duration of follow-up was 18 months, and the primary outcome was annualized bleeding rate, which is a patient-reported outcome. Some bleeds are obvious when you cut yourself, but other bleeds are based off of things like redness and pain in joints and that type of thing. So there is some patient aspect where they have to assess if they're having a bleed or not. You can see that the absolute bleeding rate at baseline was 4.19 versus 1.51 post-treatment. And that did meet, I think, non-inferiority and superiority criteria. Some of the secondary outcomes were change in the overall fixed consumption because of these patients were on prophylaxis, and then many of them, all but 2, were able to discontinue factor IX prophylaxis. The 2 that did not discontinue, one of them didn't receive the appropriate dose. I think they only got 10% of the gene therapy dose as prescribed. The other one had the highest level of something called an adenovirus-associated vector inhibitor, At baseline, about 39% of patients had this, and this particular patient had the highest titer. But as far as how to assess the titers with this particular gene therapy, it's still a work in progress, I would say. But that was the patient who was not, who did not receive or was not able to stop prophylactic therapy, did have the highest titer level. So if you go to the next page, some of the limitations for this, obviously this one also has a high risk of bias, it's small, it's single arm, it's open label. The inclusion criteria and indication don't exactly align, and we do have studies in progress to see the durability of response over time. And then as I mentioned, some of these neutralizing antibody titers that are associated with the virus vector, not with factor IX, but the virus vector, make it uncertain on how to select certain patients for this particular therapy. So we can move on to the safety slide. Some of the common adverse events were increases in ALT, as well as things like headache, influenza-like illness, AST increase, CPK, fatigue, nausea, and arthralgias. The ALT increase, part of the protocol is the patients did get a corticosteroid treatment. It started with 60 milligrams of prednisone and was tapered off over a number of weeks. The mean for that was 79 days, and the range went up to 130 days. Part of that is to protect the liver. Part of it is to ensure the response of the gene therapy, because it's important to be able to have an engraftment into the liver to be able to make the factor IX activity continue after this treatment. There were 2 deaths. Neither one was thought to be due to the therapy, and some of the warnings and precautions in the label include infusion reactions, hepatotoxicity, and hepatocellular carcinogenicity. And so now if we can go back to the packet for the PA for this one, it's a little bit more complicated. So this one is also a single lifetime dose. We ask about the FDA approved indication and if there's ever been a previous gene therapy. And then number 4, we do have a question about if a patient does require continuous routine factor IX prophylaxis. If a patient does, you can skip down to number 7. And and that question is for the baseline factor IX deficiency that the patient does have. If the patient does have less than 2%, then you would go to number 8 for age. And then if the patient has a history of inhibitors, continue down a little bit, Sarah, I'll go down the other pathway in a second. Then there's a baseline liver assessment that's important for all patients, and that's also in the labeling. If a patient does not have any screening that would give you any kind of concern over liver health, it would jump down and skip the questions for specialists and just have documentation of being HIV negative or HIV positive but controlled on therapy. And then we're asking that providers provide information about enrollment in a study to understand the neutralizing antibodies. And this is in the package insert. It's not a requirement to enroll in this study. And then that would be a pathway for approval. If you go back up to where I diverted on question number 4, if a patient's not on routine prophylaxis, we have a few additional questions. One is, do they have a history of the repeated serious spontaneous bleeding or life-threatening hemorrhage that was matched the other indications on the label? If yes, we have some questions about when those happened, because there are reasons someone could have these kinds of bleedings and possibly not be adherent to therapy. You can have problems with your IV access, you can have other issues, but because this doesn't align with how it was studied, we do have patients who are not taking routine prophylaxis or perhaps not adherent to hair therapy would be reviewed specifically by the medical director. And then also if their normal factor deficiency is more than 2%, those would also go to the medical director. And if a patient does not have a history in number 5, so they don't meet any of the indications in the label, that would be denied for approval. I think I covered all of the questions on that one, but are there any questions about this particular PA? I know it's a little bit more complicated. And I know we have public comment about this one as well.
We do. Questions on these questions? Okay, hearing none. We do have Christine Donahue with CSL Behring here on behalf of the manufacturer of Hemgenix. Christine, I made you a co-host. Are you able to unmute your line?
Yes, can you hear me?
Yep, we hear you loud and clear.
Perfect.
With that, the floor is yours, and you have up to 3 minutes to address the committee.
Great, thank you. So thank you. My name is Christine Donahue. I'm a medical outcome specialist with CSL Behring. I want to thank Oregon for allowing us to comment on the proposed approval criteria for Hemgenix. Hemgenix is approved for adult patients with hemophilia B who currently use factor IX prophylaxis therapy or have current or historical life-threatening hemorrhage or repeated serious spontaneous bleeding episodes. I would like to emphasize that there is no requirement to fail factor IX replacement therapy to receive Hemgenix. The established standard of care for patients with factor IX deficiency is IV factor IX concentrate, which can be tailored to the patient's PK weight, bleeding phenotype, et cetera, to treat the patient. However, this requires a lifetime of frequent routine infusions. Additionally, subclinical non-evident joint bleeds may lead to progressive joint damage, joint replacement, and debilitating chronic pain, even with consistent use of factor IX therapy. And Hemgenix offers patients the potential for sustained factor IX activity levels in the mildly hemophilic to near normal range that allow patients the freedom to live a more regular and pain-free life. 96% of patients in the phase 3 clinical trial were able to discontinue factor IX prophylaxis. Regarding the proposed Hemgenix approval criteria from Oregon, there is a concern that patients with optimal compliance to factor IX therapy and appropriate lifestyle adjustments could be denied access to Hemgenix for not experiencing severe and life-threatening hemorrhages, as stated in criteria number 5 and number 6. In addition, the need to experience bleeds while receiving optimal treatment with factor IX therapy to qualify for Hemgenix is not consistent with the FDA label or clinical care. Additionally, we would kindly ask that you amend or remove criteria number 14, requiring patients to enroll in a study measuring pre-existing anti-AA5 neutralizing antibodies. This study is a post-marketing requirement negotiated with the FDA that will take place in the future, but as of now, this study has not been established. There is an anti-AAV5 neutralizing antibody test that's available. It is optional but encouraged, and it's not a companion diagnostic. So we can, educate you about that. And there's also a gene therapy registry that is being conducted through outside of CSL Behring through the AFN network. So we thank you for your kind attention, and I'm available to answer any questions now if the board permits.
I'd just like to jump in on question 14. It is not a requirement to enroll in that study. We are asking that the provider give information to the patient about enrollment in case they are interested.
Perfect. Thanks.
Enrollment is not a requirement. We can't make someone enroll in a study like that. That would be unethical.
Okay, thank you.
When do you anticipate that study commencing?
I'm not sure. It's in the process of being negotiated at this point. So it's up to our clinical colleagues to decide that, but it will be sometime in the future.
Does the committee have any questions? Okay. Thank you for the public comment. We'll go back to the recommendations. So again, the recommendation in front of the committee is to designate, Hemgenix. I'm going to stick with that and not attempt Sarah's proficient pronunciation. Designated as non-preferred and apply the proposed PA criteria. Any discussion about the criteria?
Yeah. Well, I'd like further clarification from the P&T committee and the staff concerning the requirement for repeated severe hemorrhaging, etc. At number 5 so the question in my mind: are there patients out there that have modest or mild symptoms from their disease based on the percentage of factor 9 that they produce, that are kind of borderline for considering a multi-million-dollar treatment of this sort, and actually would be preferably just treated with factor 9. I mean, is it a very binary, or is it very more on the spectrum, I guess?
I would just chime in, like the clinical perspective would be that it's a pretty it's certainly a spectrum.
Yeah.
And
Okay.
The threshold, like for who actually requires factor 9 prophy, that decision, it's a hard one, and it's pretty nuanced patient to patient. And I think if you need prophy, like you should certainly be eligible for this. And so I think that PA criteria number 4 is a nice, pretty generous open door to accessing this product.
Okay. Thank you, Pat. I'm good with this. I make a motion for approval.
Thank you, Doug.
Second.
All those in favor?
Aye.
Aye.
Anyone opposed? And abstain? All right, thank you.
Okay, thank you guys. Last one, and if I accidentally say the wrong letter or the wrong factor number, please forgive me, but this is a new drug evaluation for gene therapy for hemophilia A. It was in the DERP report, but the study had not been published yet, the full trial for approval, and so I went ahead and did a different new drug evaluation just on the trial. And this one is for valitocogene roxaparvovec, or Roctavian. You can go to the next slide. You'll recognize this slide. It's very similar to the last one. Hemophilia A is a factor 8 deficiency that's also an inherited recessive X-linked disorder that primarily affects males assigned at birth. It has some of the same complications, and the treatment is often factor 9 replacement on demand or prophylactically. A couple differences: hemophilia A is about 5 times more common than hemophilia B, and patients with hemophilia A are much more likely to develop factor 8 inhibitors that require them to have alternative types of therapy rather than just factor 8 replacement, compared to patients with hemophilia B, which is factor 9. You head to the next trial, or the next page. This medication was approved in June of 2023. It is also an adeno-associated virus-based gene therapy, so it's a single infusion, no myeloablation. It's approved for adults with severe hemophilia B that was defined as a factor 8 deficiency of about 1%. Without pre-existing antibodies to the adeno-associated virus vector 5 inhibitor that's detected by an FDA-approved test. So this is an inhibitor to the gene therapy specifically. If you go to the next page, this was approved by the Gene R8-1 study. It's also a phase 1 open label, single arm, non-randomized study with an intra-subject comparison. And it was changed from the baseline to the outcomes between weeks 49 and 52 post-treatment. They had 132 participants in a modified intent to treat population, and that was an intent to treat, and then those who were HIV negative. Initially, the trial enrolled HIV positive patients, but then had a protocol amendment after there was, I think, hepatotoxicity seen in a different study in a patient who was taking a hepatotoxic HIV medication concomitantly with a gene therapy. And so there was a protocol amendment. The mean age was about 31, 71% were white. These patients, most did not have any problem joints, and 12% had one problem joint. The inclusion criteria included adult men who had severe hemophilia and regular exogenous factor 8 prophylaxis for at least a year, and no history of factor 8 inhibitors. So that's inhibitor to the factor versus inhibitor to the gene therapy, which is the AAV5. Exclusion was also those who did have antibodies to the AAV5, which is to the gene therapy, significant liver dysfunction, fibrosis, cirrhosis, HIV, and then Hep B and C. And then we have a duration of the trial up to 52 weeks, and then there's a 2-year extension with data published, and then there are ongoing extensions that are in process. The median factor 8 activity after treatment was 23.9 after the baseline was 1, so that resulted in a change of about 22. And if you can remember from the first slide, 22 is well above the 5% where patients often don't have spontaneous bleeding anymore. The primary outcome at 2 years was a change in absolute bleeding rate out to week 104, and that was a difference of about 4. You can see the range was 5 to 2.8 per year. And again, this is a patient-reported absolute bleeding rate. Something else to note that I didn't fit on the slide but is in the packet, let's see, the median factors, if you'll notice, there's median factor activity, and then there's also mean factor activity. And if you go look at the trial, there's a lot of, there's definitely a range. And so the mean is much higher. So it's a skewed population. So the median is going to be a lot more modest as far as the results compared to the means when you compare them. And then if you go to the next slide for trial limitations, this study, again, high risk of bias, small, single arm, open label, and limited duration. And then for safety, this one, 100% of the patients had some type of adverse event, grade 3 adverse events, which are serious, like hospitalizations, but not things like death, which would be grade 4, whereas 26% of patients. And then ALT increases that were grade 3 was 8.2%. And then just general treatment-related adverse events with an ALT increase of any amount that was thought to be due to the treatment was about 80% of patients, as well as a high number of AST increases. And this is thought to be because the transduced hepatocytes become targets for cellular cytotoxicity, and that can result in an increase in ALT because the gene is being attacked, but also it can have a potential loss of transgene expression. So this is important. Any severe adverse event was 16.4%. There were no deaths, and there were a number of infusion reactions. Because of the ALT increases and the potential to lose the effectiveness of the therapy, there's also a glucocorticoid protocol in this one, similar to the last drug, and that was initiated in almost 80% of patients. 29% also received immunosuppressants, either because they had a contraindication to glucocorticoids or they had failure to it, and that was also protocol-based. The median duration of the corticosteroid was 230 days, and most of the patients did experience steroid side effects like Cushing's and hyperglycemia. And you can see the warnings and precautions include infusion reactions, hepatotoxicity, thromboembolic events, and then the requirement for lab monitoring for factor 9 activity, as well as for inhibitors and potential malignancy. Go to the next slide. We're going to go over the PI criteria for this one. And these look similar. And in this one, the study population matches the indication. So does a patient have hemophilia A with a factor activity of less than 1? Does the patient have factor 8 inhibitors? If they do, then they're not eligible for this therapy. You scroll down to number 6, is the patient an adult? And then for this particular one, there are approved tests for those AAV5 antibodies, and patients were excluded from the study if they had them. And so if a patient gets tested for this and it's positive, then this therapy is not thought to work, and so they're not eligible. And then similar to the other one, there's a hepatic health assessment that needs to be done. And patients who have no concerns with that would skip over requirements to be further seen by a gastroenterologist or hepatologist, and would be able to, they would hit number 11, which is a requirement that the patient is willing to abstain for alcohol for a year. And that's partly because the hepatotoxicity, and that is in line with what was done in the study. And so if alcohol was added, the hepatotoxicity that we saw could be even higher. Number 12 is documentation the patient doesn't have acute or chronic infections, including HIV. And then number 13 is because of this 230-day median use of corticosteroids, is the patient able to safely use corticosteroids or immunosuppressants for at least 8 weeks if needed. And that's long-term osteoporosis, hyperglycemia, things like that. And are there any other questions, or was that the last? I think that was the last one. That was the last one. And I believe we have public comment for this one as well. But before that, are there any questions from the committee for this criteria? Okay. Roger, you're on mute.
I am. I'm clicking multiple buttons. Rick Kegler is signed up for public comment on behalf of BioMarin, manufacturer of Roctavian. Rick, are you able to unmute your line?
I am, yes, Roger, thanks.
You bet. With that, the floor is yours.
Hi, good afternoon to the board. My name is Rick Kegler. I'm a pharmacist and director payer and health outcome liaison for BioMarin. I want to thank the board for taking such quick action with Roctavian, the first gene therapy approved from the largest and longest running gene therapy trial for hemophilia. Today, I'll be available for questions and to offer some clinical outcomes which may not be readily available. The results from our year 3 data cut of the pivotal trial Generate-1 showed that patients treated with Roctavian resulted in the following safety information from year 3. So no new safety signals were seen, no treatment-related SAEs, no participants developed inhibitors or thromboembolic events, and the most common AE remains ALT elevation. Additionally, a more than 90% reduction in median ABR was seen, annualized bleed rate was seen, decreasing from 3.3 to 0.3 bleeds per year. There was a 96.8 reduction in factor VIII usage, a 94% reduction in factor VIII infusions. 73% of the patients remained bleed-free in year 3, and 92% of the patients remained off prophylaxis at the end of year 3. If we look at our 6-year data set, the phase 1/2 trial, this resulted in a 95% reduction in treated bleeds, a 96% reduction in factor VIII infusion rates, and 96% reduction in mean factor VIII usage. Additionally, all the participants in the 6E13 cohort remained off prophylaxis at the end of 6 years. So I'll reinforce the importance of the availability of this important therapy, and again, thank the board for their quick action and offer to answer any questions that that anyone might have. Thank you.
Fantastic. Thank you. Any questions? No questions for Rick. All right. Questions for Sarah on the proposed criteria or the recommendation? If not, we'll entertain a motion to designate Roctavian as non-preferred on the PDL and to apply the proposed PA criteria.
So moved.
Second.
All those in favor?
Aye.
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 Anyone opposed?
Aye.
Oops, sorry. Anyone opposed? And abstain? Thank you.
Great. With that, draw your attention to page 125 if you're following along in the packet. We'll turn it over to Kathy Centena for the SGLT2 inhibitor class update.
Great, thanks, Roger. Yes, so for the purpose of this update, so look at the new evidence for safety and harms of the SGLT2 inhibitors, as well as look at 2 new drugs that have been approved. The first one, bexagliflozin, Brenzavvy, was approved in January of 2023 as an adjunct to diet and exercise for lowering glucose levels in those with type 2 diabetes. And then the second drug, so tagliflozin, brand name Inpefa, is an SGLT2 inhibitor approved to reduce the risk of cardiovascular death, hospitalizations for heart failure, and urgent heart failure visits in adults with heart failure or type 2 diabetes, chronic kidney disease, or other cardiovascular risk factors. So tagliflozin is not approved for glucose lowering at this time. A little background, this is kind of a quick overview that we do have quality outcome data for this class that goes beyond glucose lowering. So primarily if we look at cardiovascular death, hospitalizations for heart failure, and chronic kidney disease, we see improvements in these outcomes with the use of SGLT2 inhibitors. Currently, we do have a policy to PA all SGLT2 inhibitors, but our preferred agents are canagliflozin, dapagliflozin, and empagliflozin. What we're going to be talking about today are 4 high-quality guidelines, 3 new indications, 1 new safety warning, 3 randomized controlled trials, and 2 new drug evaluations. If we first look quickly over the guidelines, these actually all pertain to non-glucose lowering outcomes. The first one's from NICE, and it recommends the use of SGLT2 inhibitors for adults with chronic heart failure. The second one comes from KDIGO, or the Kidney Disease Improving Global Outcomes, in which it also strongly recommends SGLT2 inhibitors for adults with type 2 diabetes and chronic kidney disease, all the way down to an eGFR of 20 mils per minute per 1.73 meters squared, which is lower sometimes than even what you see recommended in the package inserts, but they are finding that in these patients that it is safe to use in that population. The next one comes from Canadian Cardiovascular Society, which recommends the use of SGLT2s for those with type 2 diabetes for the treatment of heart failure and chronic kidney disease. And then the last one from the ADA recommends the use of SGLT2s for glucose lowering, as well for, again, for cardiovascular and renal benefits in those with type 2 diabetes. We move on to some randomized controlled trials. We see the first one, DELIVER, is a study between dapagliflozin and placebo. And this was done in adult patients with or without diabetes, but with heart failure with preserved ejection fractions. And for the primary outcome, a composite of worsening heart failure or cardiovascular death, dapagliflozin was found to be superior to placebo with an ARR of 3.1% or a number needed to treat of 33. In the second study, the DYNAMO study, empagliflozin was compared to linagliptin or placebo in adolescent patients with type 2 diabetes. And for the primary outcome of change in HbA1c, we saw that empagliflozin was superior to linagliptin and placebo for lowering glucose in this population. And then lastly, the next newer study is the EMPA-KIDNEY study that looked at empagliflozin 10 milligrams in patients with or without diabetes compared to placebo. These patients did have chronic kidney disease as well. And they looked at, for the primary outcome, which was a composite of progression of kidney disease or death from cardiovascular causes. They did find that empagliflozin was superior to placebo with an ARR of 3.8% and a number needed to treat of 27. Next, we're going to talk about a couple or three new indications, rather. The first one is for dapagliflozin. And again, this was based on the DELIVER trial that we just discussed. But in May of 2023, it received an expanded indication to reduce the risk of cardiovascular death, hospitalizations due to heart failure, and urgent visits due to heart failure in adult patients. And this expanded indication does apply to all patients with heart failure across all ranges of ejection fractions. The next one is for empagliflozin and metformin. And in February of 2023, this combination product received an additional indication to reduce the risk of cardiovascular death and hospitalizations for heart failure in adults with heart failure. This new indication was based off of the previously presented trials that we've discussed, inferior preserved and inferior reduced trials. And then the third new indications in an empagliflozin and metformin, empagliflozin is monotherapy as well as in combination with metformin. And it received the approval for the use in children and adolescents, again, based on that DYNAMO study that we just discussed for those 10 years of age and older with type 2 diabetes. As I mentioned, based on the DYNAMO trial. The next slide is just a safety warning that applies to all SGLT2 inhibitors about our drug interaction with lithium, in which it may decrease lithium concentrations, and so serum lithium levels should be monitored. Now I'd like to talk a little bit about the new drug dapagliflozin. Again, it's SGLT2 inhibitor, as we discussed. It's given once daily in the morning as a 20 milligram tablet with or without food. The approval was based on 4 different trials. The first trial was a non-inferiority trial comparing it to sitagliptin, in which it was found to be non-inferior for hemoglobin A1c reduction and superior as far as body mass changes or weight loss, with a mean difference in weight loss there you can see of about 2.5 kilograms. The next trial looked at, it was a superiority trial of dapagliflozin versus placebo. And again, looking at HbA1c, it was found to be superior to placebo with a mean change of about 0.37%, placebo-adjusted comparison there. and that it also helped reduce body mass, and that should say placebo, not sitagliptin. I got a little excited with the copy and paste, but the numbers are correct. But it was superior to placebo in that regard as well. And looking at the next two trials, the next one was a non-inferiority comparison to glimepiride, in which it was found to be non-inferior based on HbA1c reductions, and again associated with a superior weight loss compared to placebo. And then the last trial was another placebo-controlled trial in which it was superior to placebo in lowering glucoses, with a mean difference there of almost 0.8%, which again is pretty standard for this class. We see anywhere from about 0.5 to about 0.8% in glucose reduction. So they're considered moderate in that category, but again, they have other benefits as well. But this is pretty consistent what we see for the class. So some limitations is that, again, a lot of these trials were a little bit smaller, short-term studies for majority of the evidence. In the non-inferiority trial, comparing it to glimepiride, that glimepiride dose could have been increased a little bit to 8 milligrams a day, which may have underestimated the glucose-lowering effects of glimepiride, and that it was only the max dose in that trial was only 6 milligrams. Again, additionally, predominantly this population was comprised of white males with moderately uncontrolled diabetes that were on metformin therapy. And the population study was a little bit older than what we traditionally see in the Medicaid fee-for-service demographic. Looking at clinical safety, nothing surprising here. Again, what we commonly see with other SGLT2s, such as increased urination, increased UTIs, female genital mycotic infections. These are all pretty standard, so you don't have to go over those in too much detail unless anyone has questions. And same thing for severe adverse effects. They're similar to the other agents. So moving on then, we'll go straight into sotagliflozin, the next new drug here in the class, brand name INPEFA. Again, this is SGLT2 inhibitor, but it also inhibits SGLT1, which is thought to be associated with some gastrointestinal adverse reactions such as diarrhea. And then the SGLT2 helps reduce the renal absorption of glucose and sodium and downregulates that sympathetic activity. And so I just mentioned this because we don't know the exact mechanism that confers the cardiovascular benefits we see with this class, but it's thought to be changes in volume diuresis and volume status as it plays into the mechanism there. Again, I already went over the FDA approved indications, so I won't reiterate that. We'll go right into the studies there and what they looked at. This drug was actually studied in 7 different trials. We'll start out with the heart failure trial since that's what it's indicated for. The first trial, the SCORE trial, was done in type 2 diabetics with chronic kidney disease as well as additional cardiovascular risk factors. And the primary outcome in this was the composite of total cardiovascular death from cardiovascular causes, hospitalizations to heart disease, and urgent heart failure visits. We can see there that sotagliflozin had fewer events, so 5.6 events per 100 patient years, compared to placebo that had 7.5 events per 100 patient years, which was statistically significant. As well, it also helped to reduce the number of heart failure hospitalizations, as you can see there, by a hazard ratio of 0.67, that was also statistically significant. And then the next trial, the SOLIST trial, that looked at individuals that had type 2 diabetes that had just been hospitalized due to heart failure and had received IV diuretic therapy. So these were post-worsening heart failure patients that either had treatment initiated in the hospital or 2 days post-discharge. In this population, sotagliflozin was also found to be superior to placebo with 245 events compared to 355, as well as it also did decrease the number of heart failure hospitalizations. The next 3 trials are actually type 1 diabetes trials. We see here they're very similar in how they were designed and the patient population that they enrolled. So they were all in type 1 diabetics and had an insulin requirement as well, which would make sense. And what was found is that when we look at the HbA1c change at 24 weeks, sotagliflozin was superior to placebo. As you can see there, their placebo-adjusted decreases in the first two trials. And then in Tandem 3, the third trial there, they looked at the number of patients that had hemoglobin A1c levels less than 7% with no severe hypoglycemia. And sotagliflozin again was superior to placebo with an ARR of 13.4% or number needed to treat of 8. And then the last two trials were renal trials, again, very similar in design. The first one was a little bit different in that it had a slightly lower EGFR inclusion criteria. So these were type 2 diabetics with chronic kidney disease with EGFRs 15 to 30 over 52 weeks. And they found that sotagliflozin was superior to or in this one, I guess it wasn't superior, sorry, to placebo for glucose lowering, which we know that these agents sometimes don't work as well in patients with chronic kidney disease, but still usually they do retain some efficacy in glucose lowering. And then the next trial we look at, again, it's really similar in that it enrolled type 2 diabetics with stage 3 kidney disease, but the EGFR ranged from 30 to almost 60 mils. And we see there that the differences between placebo were statistically significant in glucose lowering, although still fairly modest. So some limitations to these studies. The trials conferring cardiovascular benefit were studied in patients who were older and at high risk of developing cardiovascular events. We also see that the benefit was mostly driven by reductions in heart failure hospitalizations. And then in the trials looking at glucose lowering in type 1 diabetics, all of those individuals also happened to be overweight. And then again, those trials were often small, and the glucose lowering effect, we don't know if it will be sustained because they're also a pretty short duration. Then looking at the clinical safety of sotagliflozin, again, real similar to the other agents in the class, so I won't go over those in detail, but something that's important to know is that sotagliflozin was not approved for type 1 diabetes due to an increase in diabetic ketoacidosis compared to placebo. And in the package insert, it does state that sotagliflozin significantly increases the risk of DKA, and it's not indicated for glycemic control. So that's an important distinction and adverse effect that should be, patients should be aware of if they were to take sotagliflozin. And it was also seen, I should mention, in type 2 diabetics, but not to the degree as it was in type 1. So then I have some recommendations for changes to the PA criteria, and these start on page 160 of your handout if you want to follow along. And what the overall recommendation is to remove the prior authorization requirement for the preferred SGLT2 inhibitors. So this would greatly simplify that criteria, but I think we have a lot of good outcome data as well as clinical guidelines that are recommending these first line for patients with diabetes and even those without. Additionally, many of the agents in the class have their FDA approved indications for individuals without diabetes. So the recommendation would be to remove the PA requirement for those preferred agents, and then those non-preferred agents would go through this next set of revisions, and I apologize because it's a little messy as we track those changes, but you can hopefully follow along. And the first one is just, again, the standard wording of what diagnosis is being treated. And then number 2, again, the standard wording that if they're asking for a non-preferred product, would they switch to the preferred product? If not, in number 3, do they have type 2 diabetes? Then yes, they could get that non-preferred product. Then in number 4, do they have heart failure and they're requesting one of the SGLT2s that has demonstrated cardiovascular benefit? We have some examples there. Again, some of those, if agreed upon, that the preferred agents would not require a PA. wouldn't necessarily hit this, but just we thought it would be appropriate to leave that in there to be complete. And then moving on, number 5, if they don't have heart failure, does the patient have chronic kidney disease and is requesting an SGLT2 inhibitor demonstrated renal and cardiovascular benefits? And again, then if they do, then that would also be approved. So we would, the recommendation is to remove the renewal criteria as well, as these would be approved for 12 months at a time. So the recommendations then are no changes to the PDL based on the review of the recent clinical evidence, to update the prior authorization criteria to allow for those preferred therapies to be used first line in the treatment of type 2 diabetes, as well as other indications, and then maintain bexigalflozin and sotagliflozin as non-preferred, and then evaluate costs in executive session.
Great job, Kathy. Any questions for Kathy?
This is Eddie. I have a question on the number 2 in that approval criteria.
Mm-hmm.
So is this saying that if for example, I don't know, it looks like the combo products are non-preferred. So the prescriber is ordering a Synjardy combo, and they want to continue with that non-preferred product. If as long as it's for diabetes, then it is approved. Because it says in number 2, if the answer is no, go to number 3, and if they have diabetes, then it's approved.
Mm-hmm. Yeah, then it would be approved.
So does that essentially mean that for diabetes, any product is going to be approved, even if it's non-preferred?
Mm-hmm. Yeah, true. Yes, it would. We just, we would hope that they would use the preferred agents, because those usually have the, either clinical or economic reasons for preferring them. But yeah, if they feel like for some reason those would work for them, then they could get the others would be available.
Okay, just want to make sure I was understanding that correctly.
Yeah, sure.
Good question, Eddie. Any other questions?
Not a question, just a comment that I'm very happy to see this. So thank you.
Thank you, Stacy.
You're welcome.
We don't have anybody that signed up for public comments, so if there aren't any other questions, we would entertain a motion to approve the recommendations.
So moved.
Thanks, Eddie and Robin.
Second.
All right, all those in favor?
Aye.
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 Anyone opposed? And abstain? Thank you.
Great, thank you. With that, if you're again following along in the packet, point your attention to page 164, Alzheimer's class drug class update, and we'll turn it over to Dr. Dave Engen.
Hey, thank you, Roger. Yeah, so today I'll be reviewing the Alzheimer's disease drug class. We'll go ahead to the next slide, please. Yeah, we'll briefly examine the new literature since the last time this class was covered, and also look at the safety and efficacy of the new drug lecanemab. Next slide, please. So Alzheimer's disease, it's an irreversible progressive disease of neurological degeneration, along with memory impairment. There's no cure for AD, so therapy is mostly supportive, may consist of non-pharmacologic and behavioral interventions, and pharmacotherapy for such as acetylcholinesterase inhibitors or memantine, mainly used for symptom management. The hallmark of AD is beta amyloid plaques, which can be observed in a PET scan or measured in the CSF. At this time, plaque removal has failed to show improvements or slow decline of cognition or function or symptoms in patients with Alzheimer's disease. Anti-amyloid beta monoclonal antibody treatment, it's been employed, but its use has been somewhat limited likely due to unclear clinical advantages, high costs, and potential safety concerns such as ARIA, that stands for amyloid-related imaging abnormalities. That includes brain swelling and or microhemorrhaging. Next slide, please. So there are a few systematic reviews that looked at drugs in this class. Both of the ones here looked a lot of the same studies, and in general, they found a similar magnitude of benefit for the drugs in their reported cognitive and functional type outcomes. There's low quality evidence from a systematic review that in people with dementia and taking acetylcholinesterase inhibitor, a discontinuation of treatment may be associated with worse cognitive function in the short term, so up to 2 months. And in people with vascular dementia or vascular cognitive impairment, there's high quality evidence that donepezil and galantamine daily result in a modest beneficial effect on cognition compared to placebo over about 6 months. There was also moderate quality evidence from 2 randomized controlled trials that donepezil may slightly improve functional performance in people with these conditions. But galantamine, donepezil, and rivastigmine may be associated with slightly more adverse events compared to placebo based on low quality evidence. And that's about it for those systematic reviews. Did want to go over some relatively new FDA safety alerts. So came out fairly recently. One in late 2021 with a warning for galantamine and its potential to worsen extrapyramidal symptoms. And then one for aducanumab, known as Aduhelm, came out earlier this year, warning about increased risk of ARIA in patients homozygous for the ApoE4 allele. FDA suggests getting patients tested for carrier status. Those mainly for the safety alerts. As far as the new drug review, we'll look at lecanemab. It's a human IgG1 monoclonal antibody, and it's directed against amyloid beta. It's approved to treat patients who have mild cognitive impairment or mild dementia due to Alzheimer's disease. However, the safety and effectiveness of treatment at earlier or later stages than that, rather than the mild version of AD, is unknown at this time. So looking at the 2 trials, there were 2 of them, and one was a phase 2B. That was the one that was mainly used for, or that was the one that was actually used for approval. And then there was one follow-up phase 3 trial. Both were double-blind, randomized controlled trials versus placebo. The phase 3 trial was about twice the size of the 2B trial. The study included older patients, so between 50 and 90, roughly equal participation by sex. Most were ApoE4 carriers and had mild AD. The phase 2 trial failed to demonstrate a difference from placebo in the primary outcome measure. While the phase 3 trial demonstrated a small but statistically significant change from baseline in the CDR-SB score, and put in context, roughly a half a point on an 18-point cognitive and functional scale. So both trials did show a change in brain amyloid. So I want to discuss just a few limitations to these studies. So as I mentioned, the phase 2B trial failed to meet its primary endpoint. So that was a change in Alzheimer's disease composite score. And even though the phase 3 trial demonstrated statistical significance in cognition score, the clinical significance of that is uncertain based on findings in published literature. The agent lecanemab was only studied in patients with early AD or mild cognitive impairment. So it's difficult to determine what role this therapy might play in patients as they progress to later stages. And then, as with many studies, there was an underrepresentation of non-whites, which may limit the applicability to more diverse groups. Amyloid, it's considered a surrogate marker of AD progression, and we've not yet seen undisputable evidence that reductions in brain amyloid result in clinical improvement. And since the trial was 18 months, really we need longer trials with more robust populations, possibly to determine lecanemab's true place in therapy. So I wanted to just discuss a few clinical safety aspects. So not surprisingly, there are more infusion-related reactions and ARIA events in the lecanemab group compared to placebo. But overall, the incidence of other adverse effects were fairly similar between both groups. And I'd like to take just a few minutes to look at our PA criteria. Here, we've simplified the tables and may actually look a little bit different than what's in your packet. Simplified that, but we added lecanemab to the table along with the timing of the baseline assessments that are suggested on the label. So a brain MRI and periodic monitoring with MRI are recommended at regular intervals to monitor for ARIA. Next slide, please. So as before, the criteria requires a proper diagnosis and specialist input. And we added a question to ensure it's being used in the appropriate age group studied. And the next slide, there weren't really much, there wasn't many changes there. Just 7 to 10, question 7 to 10 ask about baseline safety and see efficacy assessments. So there's nothing really new there. The next slide, number 11 was modified mainly due to that FDA safety labeling. So we ask that the patient be tested whether or not they're carriers for that ApoE4 gene, since it's a negative risk factor. And then below that, you can see the renewal criteria and how it requires follow-up documentation for safety and efficacy assessment. And it should be the last slide, and it's kind of more of the same type of assessments are needed for both aducanumab and lecanemab to determine if the patient's tolerating treatment and whether there's an improvement or stabilization or slow decline compared to what would be expected. So based on that, the recommendations would be to create a new PDL class, monoclonal antibodies for Alzheimer's disease, designate lecanemab as non-preferred on the PDL, and implement PA criteria for lecanemab and update the existing criteria as proposed. Take questions if there are any, and there may be one public comment.
Good job, Dave. Yep, we have one public comment there, but any questions for Dave first?
Question, the patients that were enrolled in the studies, is there any indication that they had tried acetylcholinesterase inhibitors previously, or was that an exclusion of the study?
Yeah, I believe they were allowed to, they were not necessarily excluded from the study if they were on those. And I think if you look in in the evidence table for the, at least for the 2B trial and the phase 3 trial, you'll see roughly what half of them were on some type of ACHI or PI or memantine. So they could be on they could continue with those medications, I believe, with this trial.
Thanks, Eddie. Any other questions for Dave? Okay, we do have a representative of Biogen, Linda Finch. Linda, I have made you a co-host. Are you able to unmute your line?
I have unmuted. Can you hear me?
Loud and clear. With that, the
Okay.
floor is yours for up to 3 minutes.
Okay, great. Thank you. So my name is Linda Finch. Good afternoon. I'm a medical account director for Biogen, and we are the manufacturer of aducanumab. And I'm actually was planning to yield back the majority of my time today and let you know I'm available for questions. But I did notice one thing in your authorization, your PA criteria for the 6-month reauthorization, that you're asking for confirmation of amyloid reduction by imaging or CSF testing. And I just want to make a practical suggestion, since the majority of amyloid removal actually occurs in the first 6 months, to 1 year. You're not going to see a lot of reduction beyond that. It really isn't necessary to repeat the testing every 6 months, and amyloid PET scanning is expensive, and it's not widely available. And then CSF testing is done via lumbar puncture, so that's invasive to the patients. So limiting those tests would really benefit both the health care system as well as the patient. And it's just really not going to give you very much information beyond the first 6 months. So with that, I yield back my time and I'm available for questions.
Naive question from me. So if the majority of the amyloid removal is done in the first 6 months, is there a need to continue with the therapy beyond 6 months to a year?
So it's an excellent question. So we don't know what happens beyond that, if there will be reaccumulation, which is why the therapies are continued. But that is something with, more data needs to be studied. And there actually are agents that in development where they are proposing that you would treat until the amyloid is removed and then you would stop treatment. But it's really an unknown, there's an unknown outcome there. So we don't really know, but excellent question.
Just a quick follow-up question to that. So, and I'm not sure that this applies necessarily to the BA criteria, but my understanding, I think Dave said this as well. So if we're measuring amyloid reduction, but we're not sure that amyloid reduction correlates with improved clinical outcomes, does that make sense?
And are you asking me that question, Sarah, or in the committee?
Yes, whoever wants to answer that.
I think you're basically at.
I was just going to say it's the target of the drug, so that's why we measured in clinical trials. But in terms of clinical surveillance, there isn't really a good reason to be measuring it.
I guess, Stacy, you're questioning the utility of the renewal criteria?
Kind of. I mean, yeah, because I mean, to the presenter's point, these are not necessarily easier or low cost tests that we're talking about. And if what we're measuring, if we're not sure that that actually correlates to any improved outcomes, I don't know that I want to.
Yeah,
I would recommend.
I guess at least the MRIs, it's just worth acknowledging, are sort of indicated just by the FDA label. So I guess that's sort of cost neutral, but I agree that how much can we really glean from post-MR response?
Well, and I guess is the opposite true? So if there isn't a reduction in amyloid on those repeat tests, does that correlate with does that mean that this product isn't working? So would we test it just to see whether or not there's progress or whether there is no progress?
I mean, it was my understanding in reading through, the FDA's response, especially that 2B that they based it on. It was almost like they were saying, okay, there's no clinical benefit according to this scale measurement. However, we see that there's, it's working on the plaque removal. So it was almost like, therefore, we'll kind of see what happens in future trials. So it kind of, in a way, it appears to be hinging on whether or not there can be a link between these clinical outcomes, plus amyloid removal and showing a clinical benefit. So it's kind of a back and forth argument, and I can understand just removing that from the renewal criteria, but there's also the question of that that was kind of one of the targets that they're looking at to begin with. So it's a difficult question to answer.
Yeah, I know. I mean, I understand both sides, but I mean, it just seems to me like I would rather have renewal criteria be based on whether or not there's clinical improvement versus measuring something that would be expensive and invasive that we're not actually sure whether or not that measure correlates with improved clinical outcomes. We're talking about moderate at best clinical outcomes. Sorry, I'm channeling Bill. Can you tell?
So I can certainly remove that renewal criteria, that number 3.
And I know that the renewal criteria number 1 is kind of based on the findings of the trial. Do we know if those demonstrated improvements are clinically meaningful improvements in those rating systems?
At least for the CDR-GS score, I should have put something on the table where, depending on the patient being treated, it's anywhere from 1 to 2 points is clinically significant. As far as the other 2, it's variable. That was, I believe, there may be some aspects of that. Looking at the lecanemab trial, I would have to dig back into those, but I think, yeah, it could be the type of thing where we, I think we're just kind of leaving it open to the prescriber in using, a validated scale to make future assessments on whether the drug should be continued or not. So the first one, yes. The second and third it's somewhat leaving it open. We're just making sure that we have the right population there. And then number 2 and 3 is, well, I guess now it would just be 2 and then 4. I mean, really 6 is where we're getting at the improvement. So I'm not sure if maybe 1 is redundant.
Mm-hmm.
Yeah, I would agree with that.
And then, so getting rid of number 1 and then number 3 might clean it up a bit.
Yeah, I think if we're leaving it open, it's number 6 makes sense. because then you're leaving it up to the prescriber to provide that evidence of clinical improvement compared to baseline.
Right.
But one creates a standard definition of who's potentially eligible. So someone with an MMSE score that's less than 22 would no longer be eligible. So if you remove one, you get rid of that.
Right,
Is there a way to combine 1 and 6 that hits everything without duplication?
Yeah, I would just have to toy with that, but I guess.
Oh, and I'm sorry, I was reading it wrong. I misunderstood. Criteria 1 is really getting at, is this person still considered to have mild cognitive impairment?
Yeah, so getting the right population group.
Yeah. So I definitely agree with taking out 3.
Mhm.
If everybody if we think 1 and 6 are getting at enough different information, we could just leave them the way that they are.
I think they're different.
Yeah, I think so too.
Sounds good.
Good discussion. So the recommendations then again are to approve this criteria as amended with removal of question number 3. And the other recommendations.
So moved.
To designate lecanemab as non-preferred. And obviously we're creating a new class for the monoclonal antibodies. So, and then the PA criteria. So sorry, I had that scattershot. So I heard a move to approve as amended.
There a second?
Sir.
Second.
Thank you, Robin.
All those in favor?
Aye.
Aye. Aye.
Anyone opposed? And abstain? All right, thank you.
Good discussion. We're a little ahead of schedule, and we're not quite at the point at break. If it's okay with the committee, I would propose we do one more topic, the VMAT2 inhibitors, and then take a break. Anybody opposed? Hearing none? Cool. Appreciate it. We'll draw your attention to page 192 in the packet and turn it over to Deanna.
Thank you, Roger. All right, we're moving into a different topic, the vascular monoamine transporter 2 inhibitors, or from here on out, I'm going to call them the VMAT2s. If we could go to the next slide, please. So the reason we're doing this drug class update is to review any new evidence for the 3 VMAT2 inhibitors, valbenazine, deutetrabenazine, and tetrabenazine. These agents are approved by the FDA for treatment of adults with tardive dyskinesia or Huntington's chorea that's due to Huntington's disease. The other reason we wanted to look at this class is because OHP's been getting some requests for off-label use of tetrabenazine in either tardive dyskinesia or Tourette's syndrome. So we wanted to see if there was sufficient evidence to support any requests that we get for that. So just as a reminder, the last time we reviewed this class was in 2018. And at that point, Kathy Centena reviewed the evidence for the 2 newest VMAT inhibitors, which were valbenazine and deutetrabenazine, which had recently received FDA approval for management of tardive dyskinesia and Huntington's chorea. The recommendations were based on low quality evidence from small short-term studies that were primarily funded by industry. Prior to the approval of these 2 newer agents, the only FDA-approved VMAT2 inhibitor was tetrabenazine, which actually entered the market in 2008 to use in patients with Huntington's chorea. So if you're interested, we do have prior authorization criteria for these drugs. They're on page 212. All 3 of these drugs are non-preferred on the preferred drug list, and the PDL status is on page 208 if you're interested. We could go to the next slide, please. So this table is reproduced from the one that's in page 195 of the packet. Excuse me, I want to note the black box warning for valbenazine is not included in the packet. That was recently added because valbenazine recently received FDA approval this year to also treat Huntington's chorea in adults. The reason I put this table together is because there's several characteristics that differentiate these medications, including the FDA approval. You'll see that tetrabenazine is only approved for Huntington's chorea. It does not have the tardive dyskinesia approval. There's differences in how frequently these drugs are dosed, whether they should be given with or without food. And then because these are all hepatically metabolized, there are some drug interaction concerns. If people have severe hepatic impairment, tetrabenazine are contraindicated in patients that have any degree of hepatic impairment. Valbenazine can be used in patients with moderate to severe hepatic impairment, and the dose needs to be adjusted. As I mentioned, all three of these carry black box warnings. The black box warning has to do with the risk of depression and suicidality that's observed in people with Huntington's chorea. And part of that has to do with the Huntington's disease. The disease state itself lends itself to people experiencing depression because they lose their ability to complete activities of daily living. In the first quarter of 2023, we did not have any utilization in fee-for-service for valbenazine or deutetrabenazine in the fee-for-service patients. We had one patient that had a claim for tetrabenazine, which I'm assuming was probably for Huntington's chorea. So I did put a note there about the off-label uses, which are cited in Micromedics, which is considered compendial by CMS for tardive dyskinesia and Tourette syndrome. Next slide, please. So since our last review in 2018, there have been 2 systematic reviews that have been published. So the first was this 2018 Cochrane review that looked at new evidence for tardive dyskinesia. They looked at a whole range of treatments. I'm just going to focus on the VMAT2 inhibitors because that's what this class update is focused on. So in that systematic review, the authors cited one small, moderate quality study that showed benefit of valbenazine in alleviating tardive dyskinesia, but it was a very small trial, only 92 patients. So the Cochrane reviewers concluded that additional data from ongoing trials was needed to confirm the results from that one small trial. The remaining evidence that was presented was insufficient to draw any conclusions about treatment of tardive dyskinesia. And then in the 2022 meta-analysis, that looked at efficacy of VMAT2 inhibitors in treating chronic tic disorders, including Tourette syndrome. The gold standard scale that's used to assess change in tic severity is the Yale Global Tic Severity Scale. I did put a table together. Actually, I borrowed what Kathy had put together in 2018. On page 210 of the packet is a description of all the different scales that are used. There is no minimal clinically important difference for this Yale Tic Severity Score. And it does have some limitations. It only captures tic severity in the past 7 days, and it might be insensitive to tic reduction in patients that have frequent symptoms. The bottom line was this meta-analysis showed that there was no difference between placebo and either valbenazine or deutetrabenazine in reducing tic severity. So consequently, neither of these drugs have off-label evidence for use in Tourette syndrome. Next slide, please. We had 3 high-quality guidelines that were issued in the last couple of years. The first was the one from the American Psychiatric Association, which published updated guidance for managing schizophrenia treatment in 2020. And they recommend for patients that have moderate to severe or disabling tardive dyskinesia that's associated with antipsychotic therapy, that they be treated with a VMAT2 inhibitor. And this is a strong recommendation based on what the authors of the APA guideline felt was moderate quality evidence. The APA guidance was supported by an AHRQ systematic review that was published in 2017. In general, the APA guidance recommends deutetrabenazine or valbenazine over tetrabenazine because there's more evidence to support their use in tardive dyskinesia. The data on tetrabenazine has a higher risk of bias because the studies were in smaller sample sizes, had inadequate blinding, and it basically yielded a low strength of evidence. In 2023, this year, the Department of Veterans Affairs and Department of Defense, VA, DoD updated their 2021 guidance for management of schizophrenia. So they revised it to include a weak recommendation that suggests a trial of VMAT2 inhibitors for treatment of tardive dyskinesia. They don't specify if it should be mild, moderate, or severe. And the VA authors felt like the body of evidence for the VMAT2 inhibitors had some limitations, including the small sample sizes, risk of bias, and study imprecision. They felt like patient values and preferences who have distressing TD would most likely want to try something if it was tolerated. And then finally, the third guidance was the European Huntington's Disease Network, which commissioned an international task force, and they provided recommendations for treatment of Huntington's disease, and they recommend tetrabenazine as first-line treatment for Huntington's chorea. There's very little comparative evidence on these drugs in Huntington's chorea, and this is from 2019, so I don't think this group has evaluated deutetrabenazine or valbenazine, but they did recommend these as first line, tetrabenazine as first line based on what they considered to be high quality evidence, unless the patient has poorly managed depression or suicidal thoughts based on that black box warning. Next slide, please. I did look to see if there was any guidance on treatment for chronic tic disorders. So in 2019, the American Academy of Neurology did publish practice guidance for treatment of tics in people with Tourette syndrome. No recommendations were made regarding using VMAT2 inhibitors in managing tics. They looked at other therapies. Currently, there are 3 FDA-approved medications to manage Tourette syndrome, and those drugs are pimozide, haloperidol, and aripiprazole, so 3 antipsychotics. So, unfortunately, extrapyramidal side effects limit their use. If you look on page 200 of the packet, I provided more detail about the level of the recommendation, whether it was a strong, moderate, or weak recommendation using either alpha adrenergic agents, and the 2 agents that have been studied the most are clonidine and guanfacine, antipsychotics, or topiramate in managing tics associated with Tourette syndrome. And I take a lot of time pointing this out because this impacts the revisions that we made to the PA criteria that we'll discuss in a few minutes. Next slide, please. So we do have some new formulations and indications. So in 2021, the manufacturer of valbenazine or Ingrezza added a 60 milligram capsule to the other 2 dosing formulations, which were a 40 and 80 milligram. I think adding this just allowed a little bit more flexibility for patients that had impaired hepatic function, or if they were on a drug that might interact, or if they were known poor metabolizers of CYP2D6. In those patients, the maximum recommended dose is 40 milligrams a day. Earlier this year, a new extended release formulation of deutetrabenazine or Austedo received FDA approval. The extended release tablets are available in 3 strengths, 6, 12, and 24 milligrams. This product is a little bit different because it only needs to be taken once a day, and it can be taken with or without food, unlike the immediate release formulation, which must be taken twice daily with food. So that's a little bit different. The approval for the extended release form was based on clinical trials of the immediate release deutetrabenazine. And then finally, just last month, or actually 2 months ago, we're in October now, the FDA approved an expanded indication for valbenazine to include chorea associated with Huntington's disease. This was based on a small study in 125 adults that had Huntington's disease, and basically the primary endpoint was a change in the Huntington's total motor score from baseline at week 12. That score ranges from 0 to 106, with higher scores indicating greater disability. There's no minimal clinical important difference that's been defined for this tool, but a 1-point increase does correlate with a 10% loss of abilities. And so when they compared valbenazine to placebo, the difference was around 3 points, which was considered statistically significant, and led to the FDA approving the expanded indication. There were no important adverse effects that were observed when they were studying this drug in the patients that had Huntington's disease. In particular, there was no suicidal behavior or worsening of suicidal ideation that was reported. However, they do have the black box warning now for use in these patients. Next slide, please. So I just want to go over the recommendations before I go into the PA criteria. So after reviewing the evidence, I don't think there's any reason to change the non-preferred status of any of these drugs. I do think it's probably reasonable, based on some of the PAs that we've received, to revise the PA criteria to include the use of valbenazine in patients with Huntington's chorea based on the expanded indication, and then add a trial contraindication or hypersensitivity to the 3 agents that are in the APA guideline before approving tetrabenazine to alleviate tics in people that have Tourette syndrome. And then finally, we'll review costs in executive session. So if you want to look at the PA changes, they start on page 212. So the first thing we did is, for number 2, is we thought it might be better to extend the initial review to be 3 months to allow more time to observe clinical improvement in tardive dyskinesia or Huntington's chorea. So you'll see that where we had 2 months for everything, we're extending that to 3 months for everything else. And then in question 4, we removed the specificity for which drug, because all 3 VMAT2 inhibitors are now approved to treat chorea and Huntington's disease. Next slide. Thank you. So we moved question number 10 up to number 6. So just to do the assessment for the black box warning earlier in the assessment. And then for question 7, we just moved we removed question 11 and moved it into 7. So we're looking at do tetrabenazine or valbenazine together for when it's used for severe, moderate to severe tardive dyskinesia. And again, the approval is moved to be for 3 months. And then the most substantive changes are question 8 and 9. So if it's a request for tetrabenazine in somebody with Tourette syndrome, we want to make sure that they've tried 2 of the guideline-directed therapies, and the American Psychiatric Association is referenced here in that footnote number 1. So we would like to see them try either clonidine or guanfacine, topiramate, or one of the antipsychotics that's approved, that's FDA approved for Tourette syndrome. And then to document as well what their baseline tic score, just so that when it comes up for renewal, there's some baseline to make an assessment against. Okay, next slide, please. So like I mentioned, we moved question 11 up into question 7, and then we removed the assessment for assessing the prolonged QT interval. The prescribing information has been modified since these drugs were first approved by the FDA. And the prescribing information says that these drugs may prolong the QT interval, but the degree of prolongation is not clinically significant if they're administered within the recommended dosing range. So we thought we would leave that up to the provider to do that assessment. Next slide. So the renewal criteria, we revised question number 3 to add valbenazine to be used in Huntington's chorea. And then we added questions 6 and 7 if it's for tetrabenazine that's being used for Tourette syndrome. And we want to see if there's any change in the tick score that they're experiencing, just to see if they have benefit from using the tetrabenazine in that certain situation. Some questions came up about the renewal criteria number 2. And I just wanted to remind folks that when we drafted this PA criteria initially, the primary endpoint for the VMAT2 inhibitors in the clinical trials was a change in the Ames score from baseline over 12 weeks. And the changes were almost at 2 points. Which is statistically significant, but the clinical significance of a change in the Ames score has not been determined. There's no minimal clinically important difference, and there's insufficient evidence to support that a reduction in the dyskinesia score is associated with clinical relevance. Again, that's discussed in Appendix 3 on page 210. The reason that we came up with a 50% reduction in the Ames score was because that was a secondary endpoint in those clinical trials. And what they noticed is people did, there was an absolute risk reduction of about 23 to 24 over 12 weeks when they looked at the improvement in the Ames score, with a number needed to treat of 5. And that was with both doses of the deutetrabenazine, the 24 and 36 milligrams. So that's how we came up with that renewal criteria. More recent literature has suggested that reduction in 2 points from baseline is clinically significant, but that's based on the review of the low quality industry-sponsored initial trials of valbenazine and deutetrabenazine. So, I guess we can go to the next slide. Are there any questions about the material from the P&T committee that I've reviewed? Just reiterating what
Questions
the
for Deanna? Yeah. We do have public comment. Before we go to the public comment, I'm going to turn it over to Sarah Fletcher. She took this initiative earlier today and engaged the Mental Health Clinical Advisory Group. And so let me turn it over to her to report on that engagement.
Sure. This morning, I just wanted to get feedback from the Mental Health Clinical Advisory Group, which is a state-run or state-appointed committee that is advisory to the P&T committee. And we presented a very high-level overview of this VMAT class, which they're going to look at more closely, specifically in relation to tardive dyskinesia, as that's what overlaps their area of expertise. And I just wanted to give some of the feedback regarding question number 3, I think, of the PA criteria, which is the requirement for a specialist. They did have concerns that that might be limiting for patients who have tardive dyskinesia and being able to see a specialist, and that in this particular situation, calling Opal K may not be as effective as some of the other consultations that they can do, because assessing tardive dyskinesia often involves a physical exam, and the patient may or may not be there when they're on the phone with Opal. And so I just wanted to pass that along, as well as this may be outside the purview of the P&T committee, but they were supportive if there's any way to have fast track referrals to people with psychiatry who do have things like tardive dyskinesia on top of their existing therapy, just as something that they wanted to promote, or just get the idea out there if there was any way for the state or for the P&T committee to make comments on that. So those were the comments from this morning, specifically related to question 3.
Yeah, I'm not really sure why we would need to have it prescribed by a specialist. I mean, the relative risks. Tetrabenazine, is a little more complicated, but valbenazine and deutetrabenazine, they're relatively straightforward. The prescribing is easy. Doing an Ames, requires 10 minutes of YouTube, but I don't really think that these drugs are complicated enough that they need to be restricted to specialists, and particularly, for folks in parts of the state where access to specialists is going to be pretty restricted. Where PCPs are doing 90% of the prescribing, I think they should, have the opportunity to take these drugs, considering they are literally the only thing we have that has any evidence for treating tardive dyskinesia.
Yeah, I agree with Russ 100% on that. It seems weird to me that PCPs can prescribe the drugs that may be contributing to the tardive dyskinesia, but then they can't treat it. So I'm supportive of that, Russ.
Good comments. Any other questions for Sarah before we have the public comment? And then we'll come back to the criteria and the recommendations. All right, great. Thank you, Sarah. Rochelle Yang, representative from Teva, or is it Teva? I apologize. Are you able to unmute your line?
Yep, can you hear me?
I hear you loud and clear. And with that, the floor is yours for up to 3 minutes.
All right, thank you so much. My name is Rochelle Yang. I'm part of medical affairs at Teva. Wanted to appreciate Dana for this comprehensive review and really explaining the rationale for changes. I do appreciate that. I would like to focus my 3 minutes here on the PA criteria, specifically around the TD or tardive dyskinesia renewal criteria, which, as pointed out earlier, does require at least a 50% improvement in AIM score from baseline. So my concern with having that specific, 50% or more requirement is that it is somewhat of an arbitrary threshold, and it is a fairly high bar, especially when the initial approval duration is relatively short at 2 months or 3 months as proposed. And just to kind of put that into perspective, in our randomized control trial, the AIM-TD, looking at deutetrabenazine in TD lasting 12 weeks, that was used to support the FDA approval. Most patients in that trial would not have met the renewal criteria, as they did show improvement, but it was not the 50% or more threshold. And the APA guidelines or other guidelines have not referenced, a specific AIMS reduction threshold to which efficacy of a MAT2 inhibitor is demonstrated. It may also unintentionally bias patients who start at a high baseline AIM score, or meaning that they have more severe disease. So for instance, a patient with a baseline AIMS of 12 would need to experience a decrease of 6 points, which is pretty significant, whereas a patient starting with a baseline of 6 would only need to see a decrease of 3 points. So again, my concern is that this requirement could potentially exclude patients who do have clinically meaningful improvement in TD control, as well as symptom stabilization in patients experiencing progressively worsening movements prior to treatment initiation, nor does it consider other TD attributed impacts to quality of life. So given the above, I would just ask the committee to consider changing the renewal criteria from what it is now with a specific score threshold to, a more broader AIMS reduction from baseline. I also noticed that, that's consistent with what's being proposed for the tetrabenazine and Tourette syndrome renewal criteria as well, where there is no specific threshold for renewal, score threshold for renewable, just a general, reduced tic severity for baseline based on that applicable scale. So with that, I conclude my comments. Thank you for your time.
Thank you, Rochelle. Any questions for Rochelle from the committee or staff?
I don't have a question, but I think that's reasonable. I don't think 50% is an evidence-based bar for patients to have to cross. And I think it is particularly that point that it would really bias this towards folks with more mild illness, whereas the folks with the more severe illness, are likely to have had the disease longer, or the tardive dyskinesia longer, and so it may actually be harder to treat. And so I don't think it makes sense to to restrict their access, particularly since this is the only category of medications with any evidence. So, the amount of isolation that tardive dyskinesia can cause in these folks, and the amount of impairment that it can cause, and in their daily lives is pretty severe. So, I think letting people have access to it, even if it only drops their score by a couple of points, could still really have a big effect on their lives, when they have the more severe forms. So I want I'd like to cut out that whole 50%.
So just say an improvement in or a reduction in the AIM score.
Yeah, I think with meds like these, clinical improvement is criteria enough.
I think that's reasonable. And then also, so do you want to make a motion to amend the PA criteria by removing number 3, the specialist, and then revising number 2 in the renewal criteria to remove the 50%?
Yes, I would like to make a motion to do all those things.
And for number 3, is that for all of the conditions or only specific to tardive dyskinesia?
Yeah, so it should be the one where removing the specialist for tardive dyskinesia. Yeah, that's the one. Yeah, so would that apply to Huntington's as well?
I don't think MCAB addressed that because I think that's out of their purview, but what does the P&T committee think?
I mean, I would be interested to see. Oh, you cover no one's prescribing tetrabenazine. I mean, one person's getting it, right?
Right.
And I mean, it has to be, taken 3 or 4 times a day. Like the side effects are, I mean, like, I don't think, I think that if utilization were to increase, we might want to revisit this, but if no one's prescribing it, I don't think we need to have I think it would be fine to get rid of this criteria and just keep an eye on the utilization. Because I mean, no one's using tetrabenazine.
That makes sense.
Deanna, or do you know, so you said that there were requests for treating Tourette's, like PA request. Were there multiple requests, or was it that one person and it got approved? Or
I'm going to defer to Sarah Servet on that one.
Yeah, we have seen more than one. I don't know that I can speak to like how many. I mean, it's not a lot because not many people use these meds, and Tourette's is pretty rare.
Right.
But yeah, we have gotten requests.
Okay. I think I would support just removing it then. And as Russ mentioned, just going, keeping an eye on it. If it seems like there's a explosion of use that we're potentially concerned about, we could always go back and revise. And then in the revision of the AIM score, can we make sure to say that, that there's like a clinically significant reduction or clinically significant improvement in, I think clinically significant reduction makes sense.
I think that's reasonable to add.
Yeah.
I think we just need a motion now. Unless there's more discussion.
Nope. Good discussion.
All right. I would like to make a motion to change. I can't even remember all the things we just talked about.
Modify the PA criteria as recommended.
As amended.
As amended.
So no changes to the PDL based on the evidence. Revise the PA criteria as amended, and we'll review the cost in executive session.
All right.
Do we have a second?
Second.
Okay. All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Fantastic. With that, let's take a 15-minute break, and then we'll resume and do one more topic before we move over to executive session. All right, we're wrapping up. I will stop my timer. Hope everybody had time to freshen up. We've got one more topic. So again, if you're following along in the packet, draw your attention to page 216, and we'll turn it over to Sarah Fletcher.
So this last topic is a drug utilization review, and it's on asthma rescue inhalers. So if you can go to the next slide. For the background, we have GINA guidelines, and they've been updated a number of times in the last few years, but they've started to trend away from use of albuterol and SABAs. And some of the reason that is because of monotherapy having an increased risk of severe exacerbations in patients with asthma, but also getting an inhaled corticosteroid seems to significantly reduce that risk. There's also data to support that a higher use of SABAs or albuterol inhalers has an increased risk for adverse outcomes, and that's independent of the other controller use. So daily use of more than 303 canisters in a year is associated with a higher risk of severe exacerbations, and 12 or more canisters in a year can be associated with a much higher risk of death. If you can go to the next slide. So the purpose of this was to evaluate the usage patterns and potential safety concerns associated with SABA use in the asthma population. Now, our current policy, we have different PDL classes for SABAs, ICAS, LABAs, and their combinations, and there are different utilization controls on those. There are preferred options for albuterol inhaler and nebulizer form. There are single agent LABA and ICS classes, and they do have prior authorizations for non-preferred agents, not the preferred, but to the non-preferred agents to ensure appropriate combination use with other single agent inhalers. We also have LABA ICS inhalers that only have a preferred and a non-preferred status. And on that class, formoterol combined with, there are 3 different brand name formoterol ICS inhalers, as well as a generic one that are all preferred. So there's no utilization controls on that. And then LABA, LAMA ICS combinations, there is some PA criteria on the preferred and non-preferred agents. So if you can go to the next slide. We had 4 main research questions. One of them, we wanted to look at the proportion of fee-for-service members who had claims for a rescue inhaler and also had claims for an asthma controller therapy. And by controller therapy, I mean an inhaled corticosteroid or a long-acting beta agonist with an inhaled corticosteroid. How many fee-for-service patients had multiple claims for the albuterol or SABA inhalers that could indicate overuse? And that was defined as a daily use of 3 canisters in a year, or extremely high use is 12 or more canisters in a year. Also, how many fee-for-service members had claims that indicated the overuse and had more adverse outcomes. So we looked at things like hospitalizations, asthma exacerbations, use of oral corticosteroids. And then are there subgroups of patients that may be more likely to overuse albuterol or SABA inhalers in their asthma treatment regimen? So if you can go to the next slide. Our methods, we included all patients who had a claim for a SABA or an albuterol inhaler during the evaluation window, and we excluded patients who had Medicare or some of the other limited benefit packages other than normal OHP plus, and then members with a third-party insurance that could have different utilization PDL standards for their insurance policy, as well as those who didn't have continuous enrollment in the fee-for-service or in Medicaid during the baseline and for fee-for-service during the follow-up. And if you can go to the next slide, I kind of mapped this out to make it look a little more clear. So the evaluation window, we looked for an index event of a fill of an albuterol inhaler between July of 21 and June of 22. And we also looked for an asthma controller therapy 8 weeks before or after. And we did that because 16 weeks should catch any patient who's getting a controller therapy filled every 3 months, because that is a wider window. So that way we should be able to capture if patients are on concomitant therapy. We also looked at the demographics at the time of the index event. Once you had the index event, we looked forward in the medical record 6 months to see diagnoses and medical claims. And we looked backwards in the medical record, and then we followed them forward for 6 months to see emergency department, hospitalization, oral corticosteroid scripts, as well as the total number of inhalers filled. You go to the next slide. These are some of the results. These are the basic demographics. So on the left, you can see there are 1,867 total patients who met our inclusion criteria with a SABA claim, and they're broken down by the ages based off of how the GINA guideline has different recommendations by ages. You can see most of the patients are over 18 years old. There are a few who are under 5. Almost 65% were female. And then over in the race column on the other side, nearly half of the patients were American Indian or Alaska Native. And I think that's just generally due to who is enrolled continuously in the fee-for-service population. Many patients go immediately into a CCO, but the H&A population stays in fee-for-service. And then you can see of that 1,867 patients, only 25% or 24.6% have a diagnosis of asthma in the medical records. Of those who did not have an asthma diagnosis, 5% had COPD, and there were a handful who had both. So if you go to the next slide. So this one delineates the number of albuterol inhalers filled in 6 months. And I have the asthma diagnosis group, that 25-ish% blocked out. And you can see on the left the number of inhalers filled in that 6-month time period. Most of the patients just had 1, maybe 2, but you can look down at the bottom that almost 17% of patients had 6 or more than 6 filled, which would be equivalent to that 12 or more filled in a month that I said in the background for the GNA guidelines have some increased risk of death. And that's pretty concerning. You can go over to the right and you can see the COPD diagnosis where there are 30 patients who are getting more than 6 albuterol inhalers who have COPD in 6 months, as well as those who are coming up with neither diagnosis and getting quite a number of fills each month, despite not having COPD or asthma in a medical record. And then I have at the bottom, there are 28 patients with concomitant asthma and COPD, and they're in this table falling in both columns, so they are duplicated. So if you go to the next slide, I think this is actually the most important slide of the results. So this is the concomitant controller drugs by indication. And if we look specifically in the asthma column, 58.6% of patients didn't have a controller therapy of any kind that we could find in the medical record. And only in the GNA guidelines, only for those 5 and under who have very mild disease would that be considered guideline directed. And then I've broken down SABA plus various controllers, and there is some overlap between those 2 bottom groups, but a SABA plus a leukotriene only, which could be appropriate in a very young population, but is not the most preferred for most patients, was 18. And then with SABA plus an ICS or some kind of ICS combination product, there were 36%. And then SABA plus anything else that can include TIMS, inhalers that have LABA and LAMA and all of the different things in them. But pretty concerning is that top left bubble, as well as the COPD diagnosis, asthma, albuterol monotherapy in those patients. So if you can go to the next slide. This one is trying to break down that potential patients who may be overusing albuterol inhalers by subgroups. And I mostly just wanted to pin out, because this is not specific to those with asthma. This is the whole population of 1,800. But if you look in the middle, it's by those who do have an asthma severity. And there's still a significant number of those who don't have mild asthma who are getting more than 2 of the albuterol inhalers, when it's probably more appropriate for them to be receiving a formoterol ICS combination product based off of current recommendations. Next slide. This table, the idea for this was to try to look at adverse reactions to those who may be getting a lot of fills for albuterol inhalers. I do have in the limitations to take this one with a grain of salt, because it's very difficult to know if those who have more severe disease are filling more claims, and that's why they're having the adverse reactions, versus if their disease at baseline is just worse. But you can see that the death is a little bit higher for those who are feeling a lot of inhalers, whether it's because of the inhaler use or because of the underlying disease maybe not being treated in a way that it could be is unknown. And then there are more claims for corticosteroids in those groups who are having 2 to 5 or more than 6 inhalers filled in a month, or filled in a 6-month time period. And if you go to the last slide of results, if you remember at the very beginning, we had 1,867 patients who filled a SABA claim, and only 400 or so had asthma. Of the patients that don't have asthma or a COPD diagnosis, we were curious as to why they might be getting all of these inhalers filled. And so we kind of tried to look up some of the diagnoses that were more common in those patient profiles. And we got a lot of symptomatic diagnosis codes like cough and abnormalities in breathing. Not entirely sure what to make of this, but there's more details in the chart in the packet, and it's delineated out for not just members with asthma and COPD, but I think for all of the members. And if you look at the next slide, so this DUA obviously had a number of limitations. One, it's a short point in time, and we also don't know, claims don't necessarily equal adherence, and we don't have any way of knowing if duplicate inhalers were being filled to have at multiple locations, like one at home and one at school. And so that could be falsely elevating the number of inhalers that we were seeing getting filled. Also, asthma has a few different diagnosis codes with differing severity that can change over time. There's seasonality, there's variable adherence at different times of the year. And then also those who have severe asthma may be more likely to be filling extra inhalers to have at all of the locations. And so it could be kind of skewing our data a bit. The medical data claims and diagnosis codes can be incomplete, and you can see there was a huge portion of patients who don't have asthma or COPD in the profile, and we're not sure why they could be getting it. You know, they could have bronchitis or something like that, or it could just be an incomplete medical record. We only looked at the inhalers. We did not look at nebulizer use. So someone who's exclusively using nebulizers or using both would not have fallen in here unless they just had an inhaler. So there's some missing data there. And then a significant number of patients were excluded because of our inclusion and exclusion criteria. There is a chart in the packet that shows how many were excluded at each step of our exclusion criteria based off other coverage and continuous enrollment. And then we also, I wanted to note that the timing of the window, because it was starting in July through June of the next year, there's seasonality with asthma. It probably picked up more patients who were getting asthma inhalers because of things like wildfire smoke versus pollen in the spring, which was not the initial time period for this. And then I noted in table 5 that that was the table that looked at hospitalizations, oral corticosteroids, deaths, that kind of thing. I think that those different groups are very different patient populations, and so it's hard to get a lot of draw a lot of conclusions between the different groups based off of that. So take that one with some just look at the limitations of that one as you're interpreting it. If you can go to the next slide. Based off of this, we do have a number of recommendations. One of which is to implement a one-time targeted informational fax for some of the patients that we identified in this DUE. So all of the patients who do not have a diagnosis of asthma or COPD in the medical record who are filling more than 2 albuterol inhalers for 6 months to potentially reassess their therapy and their diagnosis. All patients who are 6 or older having SABA monotherapy, which is my interpretation of the guidelines is not guideline directed for that age group. And then all patients with mild persistent, moderate persistent, or severe persistent asthma with any claim for a SABA, regardless of concomitant controller therapy, because those patients should probably be on a formoterol ICS combination. That's the preferred regimen, and it is available without utilization controls. And then lastly, for this particular recommendation, that all patients with asthma and 2 or more claims for albuterol inhalers in 6 months, which would be on track to have 3 or more in a year, which is overuse as per GINA, to have the informational fax to reassess their therapy. Our second recommendation is to implement a targeted ongoing retrojur to notify provider anytime someone has had 3 SABA inhalers filled within 6 months, and to potentially reassess therapy. And that would exclude COPD diagnosis because there are some different recommendations within that population. And then lastly, and this one is just a consideration of if we should possibly implement a quantity limit for anyone who is filled 6 albuterol claims in 6 months. And that would exclude patients with COPD. We haven't drawn up the details of that because we want to be very cautious with the quantity limit for a medication such as this, but anyone who would be hitting this would have already gotten an informational fax when the 3 inhalers were filled. So those are the recommendations. I'm happy to take any questions that any of the committee has on this DUE or the recommendations on the table.
Lots of information. Thank you, Sarah. We don't have any public comment. Any questions for Sarah?
I'll just say this was super impressive, Sarah. And to the quantity limit, my inclination is to forego doing a quantity limit, but I'm open to what others think.
Thank you. And Sarah Servid helped extensively in the methods of this DUE.
I think the quantity limit has some concerns. You know, sometimes people want one at school and one at home, you know, in different places. And so that seems like that could potentially cause harm if there's a rigorous quantity limit.
I agree. That was my comment as well. And something we tried to do at our own institution was implement some quantity controls, and we ran up against that in a lot of folks. But I do think the first 2 recommendations are reasonable to continue addressing this. And I'll probably be reaching out to you guys separately because this is a similar analysis that we're trying to run internally. And I'm really interested in your methods of how you did this.
Would a super liberal so split in the middle instead of putting a no quantity limit, would a super liberal quantity limit that would be sufficient, but would also allow for those duplicative claims at school, whatnot, and then once it reached a threshold that you would feel comfortable them stopping, or just don't put it there and continue to monitor? So, for example, instead of 6 and 6, like for the last one, if there were 9 and 6, and again, I don't remember in the data, Sarah, if there was some break, but there were some that were above it that were more egregious that you definitely want eyes on and couldn't really have a reasonable explanation for.
Well, as far as those with asthma, 3 in a year is a lot, and then 12 in a year is the one that increases the risk of death. And so that's kind of why we set that there. So it is pretty liberal,
yeah.
but also understands the concerns with wanting to put that in and not knowing if someone is filling it to have it in multiple different locations. Hopefully the rest of the provider notifications could get some people tracked onto formoterol ICS, which is probably a more appropriate therapy, at least for the asthma patients. And it could be something we can look at some more. We were pretty surprised that only a quarter of patients had a diagnosis for asthma in our system.
So maybe instead of the quantity limit, we do some kind of retrodermal pull claim. So if somebody hits 6 and 6, we do targeted outreach to their prescriber.
Yeah, we're going to do that at 3. That's the second recommendation. So
I'm glad I'm catching up.
I think it does look like there's a plan to do the notification for 2 in 6 months, which as a provider receiving that notification is really different than 6 in 6 months. So maybe I think that would need its own notification as well.
Sorry, could you clarify that, Kat?
I mean, so this is going back to what the intent of the quantity limit was trying to do. So there's a different level of concern between somebody who's getting 2 7 inhalers in 6 months and someone who's getting 6 in 6 months.
Right.
So just making sure that there's including as part of that targeted notification, hey, we're pretty concerned your patient is filling 6 in 6 months. This definitely shows that, it's inadequately controlled and we're worried, just making
okay. Having all of the fills on there versus just you've met the limit of more than 2.
Yeah, and that's where you're like your kid who gets one, who has to have one at school and one at home. Like I'll look at them and be like, that's appropriate. So, yeah, it's a different situation if they're getting 6 in 6 months.
I'm not sure that this is an option or if it will necessarily get us to what we're going for. But what about instead of a quantity limit, we did something at the point of sale so that once they reach a certain amount, then it stops. It could be overridable, but it would be something that then prompted the pharmacist at the point of sale to have a conversation with the patient. Just another mechanism to get the information out there. And if there could be messaging like, hey, your patient has used X number of inhalers, please, have them consult or you consult with the prescriber about more appropriate therapies or something. So that to me would be kind of middle ground. So it's not a hard stop where they're going to have to get a PA or anything, but it's just one other point of conversation with that patient so that they know what the concerns are coming from.
Could that be something, Roger, where we could maybe build an EOB to ask the pharmacist to assess adherence and education as far as taking the other medications that they may be prescribed? Because we don't know if how many of these are patients who are filling one thing and not the others versus, we don't know exactly what's going on with some of them.
Yeah, essentially you build the edit and lands on here. She can chime in, but we can take this offline, discuss it. So it is like it requires PA at 6 and 6, but the messaging would be specific to the pharmacy to say, hey, bringing this to your attention, but you can override this if, they've lost it, stolen, it's filled into multiple locations. So try to have that specific EOB so that the pharmacy could try to, I don't know that we could build an override that they could put in a code, but they might be suggested in the EOB messaging that they could call for an authorization.
or something. Yeah, I mean, or if it truly was a patient who needed in multiple locations or lost it or whatever, you
Right.
could override it as medically necessary. But
again, 6 and 6, as Sarah just said, I mean, that was where I was going, but that's
no, I'm
over the
thinking
top,
like
2 and
yeah,
6. Yeah.
yeah, maybe even do the messaging before that, right? So when it's, when we're after 2 claims in 6 months or 3 claims in 6 months, then that messaging comes up. And hopefully then, if the prescriber gets the message and the pharmacist gets the message and they're both talking to the patient, maybe that has a better outcome.
Great suggestions. We'll take it away and discuss what's feasible with our claims processing.
Can I just add one more comment? This is Deanna. I agree with Dr. Carr. Great work, Sarah Fletcher and Sarah Servid. I'm wondering if a newsletter would be helpful as we're rolling out this program to just kind of share what the results were and reiterate. I think we have done a newsletter, but maybe reiterating that people aren't really adhering to guideline directed therapy, and these were the results we saw in fee for service. I don't know if that's a possibility.
I think that's a great idea because
I completely agree.
that's an awesome idea, especially and including some of this data like, hey, do you know X percentage of people get an albuterol inhaler that
I'm sorry. This is Dee. I just want to flag, I think this is probably something for open discussion. Are we still in the
but we're not in
We're in open
Oh,
discussion.
sorry, never mind. Sorry, ignore me.
Roger hasn't done his blurb yet to go into executive session.
I'm sorry. I'm
That's
so
okay.
sorry.
Thank you. So what I'm hearing is, we still need a motion, but it sounds like the first 2 bullets are in favor, and that perhaps we should go back and see what options we might have as far as point of sale educational edit that's not a hard stop, and see if there are any possibilities for that. And if there are, perhaps bring them back as old business with more details on how that would be implemented. We're a little unsure of putting in a hard stop, which is why I didn't build anything to start with. And then potentially writing a newsletter for further education. Does that summarize the discussion as I'm hearing it?
I think so. That sounds good to me.
Is there a motion to approve that?
So moved.
Second.
All those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you.
Thanks, everyone.
Good conversation. Look forward to collaborating, Eddie, and getting some messages out there. So, all right. With that, we have concluded the business that we needed to conduct an open session. As Dee set the stage for, we are about to go into executive session where we're going to be sharing confidential pricing. I need to read a blurb in my best radio voice. Once we go into executive session, the audience, you won't be loud, but we won't conduct any business. We'll come back out in an open session, make any recommendations from that session. So the P&T Committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to ORS 1926602F and ORS 4143561 and 2, which allows the P&T Committee to meet in executive session to review confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that is necessary for the committee to make final recommendations or to comply with the requirements of ORS 4143553. Representatives of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive sessions except to state the general subject of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. And with that, we will go to the breakout room. Okay, we are returning from executive session. Recording has been turned back on. Just doing a quick panel check to make sure that we've got the committee all out here. They were able to unmute their lines, so got them all there. We've got a quorum. So I'm going to go through for the final recommendations and take these classes one at a time. As Dee alluded to before we went into exec, any discussions of any clinical considerations need to be held in open session. Sometimes it's hard to separate the two. So we're going to welcome conversations by the committee as we go through each of these. So going to start with topics that were part of the consent agenda. So in the CSF class update, after review in executive session, the recommendation is to make Nivepria, which is pegfilgrastim, non-preferred, as we weren't able to negotiate a supplemental rebate contract for the upcoming year for 2024. So any discussion? And then we take a recommendation or a motion to approve that.
Motion to approve.
Second.
Thank you.
Second.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? Thank you.
Next, also part of the consent agenda were the opioid reversal agents. After review of confidential pricing exec session, the recommendation is to make the Opvee, nalmefene, and the naloxone cartridges preferred, and to also add coverage for the OTC versions. Any discussion or a motion?
Motion to approve.
Second.
All those in favor?
Aye.
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 Anyone opposed? Abstain? Thank you.
Great. Moving on, also on the consent agenda was the substance use disorder lit scan. Recommendation after exec session was to make Brixadi preferred and the Sublocade voluntary non-preferred. We do have open access for the first 30 days for all agents, so that's why it's voluntary, but its name would come off the PDL and it would be voluntary non-preferred. Any discussion or a motion?
So moved.
Thanks, Doug.
Second.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
Moving on to the parenteral antipsychotics, again, consented to the topic. There were no clinical recommendations for changes. After review of exec session, the recommendation is to make Uzedy, the risperidone, preferred on the PDL. Any discussion or a motion?
Motion to approve.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
For the SGLT2 inhibitor class, recommendation after review of confidential pricing were to make no changes to the PDL. Any discussion or motion?
Motion to approve.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
For the Alzheimer drug class update, after review, no changes to the PDL are recommended. And as a recap, we're making that a new PDL class, and we're designating lecanemab as non-preferred. Any discussion or move?
So moved.
Thank you.
Second.
Thanks, Eddie.
All those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
And for the VMAT2 inhibitor class, after review and executive session, no changes to the PDL are recommended.
Move for approval.
Second.
All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
While we didn't dig into the pricing and there were obviously some supplemental rebates offered, there was a desire to have a little bit of discussion around the gene therapies. And so I wanted to open up the floor for any discussion from the committee.
Well, I certainly, with these extraordinary high costs of gene therapies, they offer a promise of markedly reduced debility to patients, to members, and annual reduction in costs. I mean, hemophilia is a very costly annual drug or annual treatment cost. But it's also a likely good outcome, but it's not guaranteed. And so I know that there is a lot of discussion in the industry to make sure that those kind of extraordinary one-time treatments come with a guarantee and or some sort of value-based pricing concurrent with it. And so I would strongly encourage fee-for-service to pursue that with these manufacturers of these one-time drugs or one-time treatments, because our CCO will certainly be doing that as well.
I appreciate that, Dr. Carr, and I'll just comment briefly. I think, to my knowledge, drug manufacturers for some of these are also interested in offering some type of guarantee. The challenge that we have is that the method is generally through something called a supplemental rebate agreement. And currently, CMS has foreclosed us from having any such guarantee for a 340B drug. And so to the extent that the gene therapy is through 340B, we're not able, from CMS's perspective, we're not able to have a guarantee through a supplemental rebate. But this is something that's active discussion, so I'm really glad that you're talking about that. I don't think anyone really, I think everybody's on the same page that they want it to be available for 340B drugs too. It shouldn't really matter. It's just a guarantee. We just need to work with CMS to get whatever changes they think they need to allow it. So I appreciate the comment and the support to remind me that this is something I need to continue to work on.
Well, and there are other states that have pursued a subscription contract arrangement and have been able to do that in their Medicaid programs, right?
Yeah, I will say that as a disclaimer, most of my research is in the realm of alternative payment models for cell and gene therapy, so I spend too much time thinking about this, but all of the subscription models are really addressing like budgetary uncertainty, whereas I think what you're most interested in, Dr. Carr, is like the effectiveness and the durability, and even the outcome-based arrangements that have been reported, and they're far and few between. The time horizon on those, like maybe 3 years, maybe 5, whereas like the true uncertainty for these products is farther out than that. So I also agree with you that we should be thinking about this, but I'm perhaps a little cynical about the real world utility relative to the costs that are incurred in implementing them. But if you ever want to talk more, I would love to geek out on this. So just
great.
I would love to geek out too. I think we could share notes. But just to follow up though, Dr. Carr, that those subscription models and things that you've heard about, they do not include 340B, or if they do, it's CMS has told us we cannot do that. So I think this is going to be for further development, and hopefully we'll get that corrected. So this is, it's a particularly an issue for treatments that are almost exclusively going to be offered through a 340B center of excellence.
I'd really love to understand what the options are in the space. I mean, it seems like this question is going to come up again and again, where we have therapies that are worth, that are easily more than $1 million or $3 million. Especially if we think about that being implemented, across the state, with smaller, bigger CCOs, like there's a real risk of financial catastrophe. So just wondering, is there a white paper that summarizes all the potential options where there's an opportunity to collaborate and figure out what the best thing is going forward for everyone? Just because there's so much financial risk that's associated with it, whether that's through a carve out or through this negotiation with CMS. But I'd just be curious as to what are the options, if there are options, just to understand.
I think some of that is kind of goes into actuarial analysis and however the budget folks figure out capitation and all of that stuff, which is definitely not my area and probably not exactly the space here. But at the CCO pharmacy directors meeting, for example, I'd be happy to have a presentation from the actuarial folks to talk about that. Because there's that aspect is definitely something that we have potentially some options. The rebate, actually trying to lower the cost and having guarantee and that kind of thing is something I'm working on, and there's been a lot of support. Lots of other states are also interested in that too, to try to get something. But Dr. DeMartini, I'm also a little bit skeptical and cynical. But it'd be nice to have it as an option at the very least, and we need to make some changes for it to even be an option, theoretical or otherwise. So, Kat, Dr. Livingston, if you'd like that to be a topic for pharmacy directors meeting, and make sure that you know about it too.
And maybe the only other thing to look forward to is that I think in the Inflation Reduction Act, they included a little blurb about, I think it was that the CMS Innovation Center is creating kind of a novel financing pilot project for Medicaid to sort of explore the feasibility of a centralized kind of alternative payment system that CMS or Medicaid would centrally negotiate and then states could join into. Nobody knows, it's like one paragraph in a bill somewhere, and they're figuring out how it'll actually work. But in the next 2 years, it will likely be used for sickle cell disease as a potential financing pathway.
That's super intriguing, Pat.
I didn't know about it. Cool.
But again, more cynicism that will it actually be anything.
Great discussion. Really welcome the engagement and all of the volunteers of this committee. Really appreciate you. Any other topics for discussion before we conclude for the day? Okay, hearing none, the final P&T meeting of the year will be held on December 7th. Details to follow. I'll certainly be sending out information. And as we stated at the top of the order, if we have physicians, pharmacists, or non-physician pharmacists, so public members interested, like Russ is our public member and nurse practitioner, appreciate that. Interested in applying for consideration for appointment to the P&T Committee or the Mental Health Clinical Advisor Group, please go over to the Oregon Health Authority's pharmacy page, and there's details there, or email me, and I'm happy to provide details or discuss it with you as well. So with that, thank you all, and have a great rest of the day.
Thank
you, Roger.
Thanks, everybody.
Thanks, everybody.
Goodbye, everyone.
Thanks.
Thanks.